So welcome everyone. Thank you for being with us today. Today is the second time that we host the Healthcare Ethics Symposium at the Markkula Center for Applied Ethics. And this symposium has been created as an opportunity for my students to showcase their work. So as many of you know, we have been working together for the whole year on healthcare ethics. And we have been discussing many topics, some of them very difficult, some of them easier, and most of the time with amazing guest speakers. And so today and tonight, I would like to thank them all for, being with me the whole year and growing so much. I'm so proud of each one of them. And you will see their presentation are really awesome. But before we get there, I just would like to give you a short, overview of the program that we are running at the Markkula Center for Applied Ethics, which is the Healthcare Ethics Internship. So I couldn't resist but, have a picture there of the cohort because, I know, I didn't tell you guys, but it's okay, right? So this is a picture we took at the very beginning of the year. I think it was October. And as you can see, all of them are here. In addition to one of our guest speakers, who is Dick Levy, who came to our class at least twice. And the students and I had the fantastic opportunity to discuss with Dick very important ethical issues around the health system in the US. Because, of course, Dick has had a very long and wonderful career in healthcare. And, of course, he knows a lot about the topic. And so I couldn't resist but show you this picture because I'm very proud of that and of each one of the interns, as I said. So a year-long program, it's experiential learning for social justice. What does that mean? It means that everything we discussed this year was about social justice. So we use different lenses on various topics. I'm sure you heard about them several times at home for the parents who are here tonight. And it was really about ethical dilemma in healthcare, but also related to technology. Because as you know, the Markkula Center for Applied Ethics is an applied ethics center. So it's not about thinking about the problem. It's also trying to find solutions together. And I think this is very important to emphasize, just because it makes us pretty unique. I would say in the field, the Markkula Center for Applied Ethics is the biggest applied ethics center of the United States. And we have the chance to have it here at Santa Clara University. My students also had the great opportunity, I think, to shadow physicians at Sutter Health. This is totally part of the program. So the program has two components: the weekly classes, where for 2 hours we discuss those topics, as I just said, but also the practical experience that was offered to them during winter quarter. And basically, I think all of them were very grateful for that experience. They could choose the specialty in which they wanted to shadow the physician. So some of them shadowed, for instance, cardiologists or OBGYNs. And so depending on their own interests. So I think, again, it was pretty unique and fruitful. Tonight, we are here to present, for my students to present their blogs. So as you can see, I mentioned in that slide the link to the blogs because almost all of the blogs have been published. And so if you follow that link, you will see, the written version of the blogs. But of course, I didn't think it was enough. I think, my students are really exceptional. And I think that they deserve an opportunity to present orally their work. And this is what they're going to do tonight. So, without further ado, because it's nothing about me, but about them, I would like to introduce you to first my Honzel Fellow, and then we will continue with every intern. My Honzel Fellow is Shelby Jennett. She was a student last year in the Healthcare Ethics Internship, and she was selected among a group of fantastic students to become my assistant this year. And so I couldn't stress enough how wonderful Shelby has been this year at every level, not only during the class, not only, to select the guest speakers with me, but also to help every one of the interns, to mentor them, as I did, and to really be with them, when any difficulties or any question would arise. And so thank you so much, Shelby. It has been a fantastic year, and I'm very grateful for you today. And so, without further ado, as I was saying, Shelby will be the first to present. And Her presentation is about transformative experiences. So please help me welcome Shelby.
Good afternoon, everyone. My name is Shelby, like Dorothy mentioned, and I was a Honzel Fellow for this year. Today, I'll be presenting on my research topic, which is Transformative Experiences, Redefining the Challenge of Informed Consent in Modern Medicine. I'm sure each of you standing in this room today has had a transformative experience, whether you know it or not. Whether it was becoming a new driver for the first time, going to college in a new town, or becoming a parent, whatever it may be. Transformative experiences are broad and diverse, but today I will be focusing on them in the context of medicine and in relationship to informed consent. So what exactly do I mean by transformative experiences? Transformative experiences are a philosophical concept coined by the philosopher Laurie Ann Paul. It has two different elements to it. The first one being an epistemic transformation, which means that you gain new knowledge of what something is like and are really able to grasp what that experience is like beyond mere theoretical understanding. So this is common to many new normal experiences that we have. Take, for instance, the example of trying raw fish for the first time. Oftentimes, whether you've heard from family members or friends what it's like, you won't actually know what it's like until you have the experience yourself. The second aspect to a transformative experience is having a personal transformation. Essentially, this kind of transformation alters one's sense of self, their identities, the way they experience themselves, and can oftentimes change one's worldviews and core beliefs, as well as what matters to them. And so taking these two aspects combined, we have transformative experiences. So some examples of transformative experiences include, but are not limited to, like I said, becoming a parent, as well as gaining or losing specific sensory abilities. And the reason that becoming a parent is a transformative experience is because it has that element of an epistemic transformation where even if you've had similar experiences, such as taking care of a young child or reading about becoming a parent, you don't actually know what it's like until you become a parent. Secondly, there is a personal transformation for most people because oftentimes when you become a parent, you really identify with what it means to be a parent. And oftentimes your worldviews and values can really be changed because now your life really revolves around this child. And so what does this have to do with informed consent? Well, I first think it's really important to highlight the history of informed consent. Today, in our doctor-patient relationships, we really see how our decisions are really protected and valued at the end of the day. But this wasn't always the case. Informed consent really dates back all the way to World War II, where Nazi physicians really unethically experimented on human subjects. And so several documents, such as the Nuremberg Code, were created in order to establish this as a protected right and really protect humans, especially in human research. And so further documents really expanded on this, establishing more frameworks and principles protecting people, especially in human research. And lastly, what really established informed consent as a legal requirement in medical procedures is the case of Salco v. Stanford in 1957. So this is the reason why medical professionals are required to obtain your informed consent no matter how big or small the procedure is. So like I mentioned, informed consent is really important. The reason being is because it protects this fundamental right to autonomy. Autonomy is one of the four main bioethical principles, which is the respect for all persons. It protects the right to make free decisions for oneself without coercion. And so what is informed consent exactly, and how is it obtained? So informed consent has two major elements to it. The first one being understanding, and the second being appreciating. So what does that mean? First, understanding means once you have the general risks and benefits, you're able to comprehend the general risks and benefits once a medical provider kind of tells you what that is. And appreciating means taking these general risks and benefits and applying it to your specific case. So to better understand what I mean by this, let's just take an example of somebody giving their informed consent for getting a piercing. So to understand in this case would mean to understand that the general risk could include infection, pain, swelling, as well as developing scar tissue. However, to appreciate their specific case means, for example, if the patient or person were to have already existing scar tissue, they understand that they may be at increased risk of developing further inflammation or scarring and things like that. So as we can see, informed consent really revolves around a person's ability to comprehend the information given to them and really weigh the risks and benefits of this specific procedure. And so what are some challenges to obtaining informed consent? Well, sometimes we might not be able to obtain informed consent if one lacks decision-making capacity. So oftentimes this can be undermined if someone isn't able to comprehend the information. Some examples of this include emergency cases. If a patient comes in and they're unconscious, then other physicians or other people will have to make decisions for them. Other examples include young children. They're not able to fully comprehend the information, and legally their parents are required to consent on their behalf. Other examples could also include language barriers, as the person wouldn't able to be truly comprehending the information to really give informed consent ethically. And so, as we can see, the current model of consent is framed this way, and oftentimes when one isn't able to comprehend information, then they aren't able to give informed consent. However, this is really complicated when we introduce transformative experiences because of the personally transformative nature of it. So if somebody were to become a more different person and have different views, it's kind of impossible to know whether somebody's going to have a transformative experience or not, because it depends so heavily on one's particulars, such as their lived experiences, beliefs, as well as values. And so no amount of knowledge can prepare you for that experience. Going back to the situation of becoming a parent, no amount of books will really allow you to appreciate what it is like to be a parent and how being a parent will change you specifically. Furthermore, no simulation can tell you what it's like to go through that experience. For example, simulations of being deaf or blind won't actually tell you what it's like to be deaf or blind, especially it won't tell you how that experience is going to change you as a person as well as your worldviews. And so the main problem here with informed consent is that because it is impossible to access this information, which is necessary for a patient to appreciate their specific case, because they become a very different person after a transformative experience, then based on our current models, it's not possible to appreciate in that case. So to understand how this applies to the clinical setting, let's just take a case as an example. So consider a patient. She is 6 weeks pregnant, undergoing a medical abortion, and she comes in seeming very sure of her decision. Her preferences are to continue her education, and she's not ready to be a parent. And so even after the clinician explains the general risks and benefits of the procedure, and it seems like the patient is able to give informed consent, the patient comes in one week following and reports having persistent anxiety, as well as a shift in her core values and belief in ways that she could have never imagined. And so this experience really changed this patient in ways that she could have not possibly foreseen. And so the worry here is that even though it seems like the patient was able to give informed consent ethically, she actually isn't based on our current informed consent models. The reason we care about this so much is, like I mentioned, we really care about people's right to autonomy, and so this is a right that we must protect. So to understand another case, let's consider another patient who has an accident with a saw. Part of their finger is left very damaged, and this is either going to result in a finger amputation or possible replantation of the finger, and after extensive work with a physical therapist, they may gain full recovery. So I really want to highlight in this case is that transformative experiences can be somewhat subjective. And what I mean by that is the same procedure from one patient to another may be transformative, but may not be for another. So for a patient who doesn't work with their hands very often, they may not gain full functioning of that finger ever again, but they're still able to go about their day, and this might not change their identity. However, we can imagine if somebody is a surgeon, for instance, if they aren't able to be a surgeon anymore or aren't able to perform surgeries in that exact way, this may really undermine who they are as a person and may cause them to have shifts in values as well as their identity, since oftentimes we really identify with our jobs and with our careers. And so we can see that this really presents practical challenges for physicians, because physicians are the ones to obtain informed consent from patients, and they're the ones who give the necessary and relevant information to their patients, because like we mentioned, it's impossible to access this type of information That would also mean it's impossible for physicians to give their patients the necessary information in order to appreciate their specific case. And then on the flip side, there are potential consequences on patients. If we treat this experience as routine and normal and don't consider the fact that it could be a transformative experience, this might give us the illusion that informed consent has been obtained when in actuality it hasn't. Like I mentioned, we really, really care about protecting one's right to autonomy. And so it wouldn't be good if we didn't ethically obtain informed consent. The second worry is that if we treat this as more routine, patients could be left feeling very misunderstood, isolated, and have feelings of anxiety, which might be caused by their healthcare provider. And so we should care about this too, because we want to provide the best patient-centered care as possible. And so it seems like there are definitely issues and limitations in our current consent models. And so what can we do about this? Well, first, we might be able to make some generalizations and kind of group based on probability which procedures are more likely to be transformative than others. While this isn't the perfect solution or able to tell us definitively which procedures are going to be transformative from one to another, we can imagine that because we really depend on our body to navigate the world, and our bodies oftentimes are associated with our own identities and sense of self, we can imagine that procedures that are going to alter the body and be irreversible are more likely to be transformative. And so there's a long list of examples here, but I've just included a few, including gynecological surgeries, gender-affirming surgeries, organ transplant, limb amputation, as well as aggressive treatment like chemotherapy. And something I want to highlight is these procedures don't have to be voluntary in order to have a transformative experience. And it doesn't necessarily depend on the severity of the procedure as well. And so this would be helpful possibly for clinicians because it might help us figure out which procedures need to be handled with more care, especially when obtaining informed consent, and when the traditional models apply and when they don't. Lastly, some other possible solutions in order to help both patients make decisions as well as providers obtain informed consent is to use more of a core values approach, which is to ask patients which values are most important to them, what kinds of things do they value on their day-to-day, and this questionnaire could be administered by physicians, and it would vary based on procedure to procedure. So this questionnaire could be procedure specific. Some examples are you the kind of person who adapts quickly to change and new challenges? And so basically this questionnaire would be asking about things that are likely to be more fundamental to the person rather than having to imagine hypothetical situations of what one's future self would be like and how one might be changed. And so this doesn't have to be done by physicians alone. The burden could also be alleviated by consulting with bioethicists, social workers, as well as behavioral therapists. And although this solution is practical, it isn't perfect. And so it really highlights this kind of limitation and gap in current consent models. Oftentimes, we can really underestimate how an experience might change us as people. And so it's really important to consider people's lived experiences, values, beliefs, and we must treat each patient as unique, especially when obtaining informed consent. Ultimately, we should really take this issue seriously and care about it because we care about delivering the most ethical, patient-centered care possible. Thank you.
Thank you so much, Shelby. Amazing. So Shelby has just presented to you her project of the year as a Honzel Fellow. On the top of, as I said, being my assistant, she ran that project. Thank you so much. Now I will be introducing my interns. So the students who were in my program the whole year as Shelby, but for the first time, and who went through the whole program and the learning. But before I do that, I would like to mention that the topics that they chose are the topics that were close to their heart. So basically, I didn't tell them you should be talking about this or about that. They were totally free to pick up a topic and to just, write about it and research and write. And as I said, most of them were published on the Markkula website. So last but not least, I would like to mention that if the audience has any question, please feel free to ask. Just raise your hand at the end of the presentation. So does any of you have a question for Shelby? Or was it all perfectly clear? Or follow-up question maybe on something she hasn't said? All right, so if not, For the next one, please feel free to ask any question you have. And here we have, thank you so much to my colleague, Monica. We will be giving you a short program for the presentations today, so you can follow, who is presenting and what titles in addition to the slides. All right. So thank you again, Shelby. And now we are with the interns. And I would like to welcome Alan Dow.
Good afternoon, everyone. My name is Alan, and my research topic today is boarding emergency department patients leads to unethical outcomes. So please imagine a scenario where a close relative to you or someone close to you is rushed to the ER, and they're subsequently triaged and assessed, but to your horror, they're not placed in a room with a door, nor walls, nor even curtains. Instead, they're placed in a hallway. And even worse, as you're looking over your shoulder, you can see in another room someone receiving life-saving CPR. You can hear bones crunching, and you can see limbs failing. Unfortunately, that scenario I just illustrated is not fiction. It's reality, and it's a reality I've seen firsthand. So, in September 2023, nurses at UC San Diego's La Jolla Medical Center protested outside the emergency department, advocating for increased awareness about emergency department boarding and overcrowding. Boarding is the practice of retaining patients in hallway beds, hallway gurneys, and hallway chairs as opposed to a private room. And as we can start to imagine, this creates a lot of negative outcomes, some of which include increased waiting times in hospitals, increased length of stay, higher patient dissatisfaction, increased patient mortality, staff burnout, and not only that, increased financial burden on hospital systems. So the crux of the issue is overcrowding, which is defined as an imbalance between the supply and demand as it relates to an excessive number of patients waiting to be seen, treated, and ultimately moved on from the ED. And evidence-based research suggests that there are three main factors contributing to overcrowding. First and foremost, we have input factors. This is why patients show up to the ED, and this can be affected by a multitude of things. Sometimes patients present with severe complications requiring higher medical care, and thus they have to go to the ED. Other times, there are disparate access to primary care resources. Patients are not able to get routine checkups with a primary care physician or get longitudinal care, so they rely extensively on emergency medical services. Other times, we have seasonal illnesses. Think in the fall or winter times, we have increased rates of respiratory and viral illnesses, so more patients are sick with pneumonia or influenza, for instance. And then viral outbreaks, something we're all familiar with from COVID-19. These are really unpredictable. Patients with pre-existing health complications get really sick if they develop COVID-19 and severe complications and thus have to go to the ER more frequently. So as we can start to see, these input factors are things that we can't necessarily control for. So intervention tactics are primarily focused on mitigation. Moreover, we have throughput factors. This is the time that it takes to treat and process patients within the ED. And this can be delayed by many things, such as staff shortages. There may be not be enough bedside nurses, advanced care providers, or physicians to go around and treat every single patient. Another delay can occur in delays in diagnostic imaging. One patient might be able to wait 30 minutes for an X-ray or CT scan, while another might have to wait 2 hours, and this can cause delays in the time that they are in the ED. Another time is getting specialist consultations. When a patient has a complex situation, physicians often consult specialists, and these specialists are busy during their inpatient rounds and having to come into the ED and see the patient, and this can all cause delays. And lastly, we have output. This is what brings patients out of the ED. So traditionally, patients can leave the ED via discharge when they're medically stable enough to return home, admission when they're still very ill and still need to stay in the hospital for longer, and as well as transfer. Maybe another facility is better equipped to handle their medical emergency. So when it pertains to boarding and overcrowding, the admission stage is really, really impacted because our admitted patients ED are waiting for inpatient beds, but these are a finite resource. So patients are unable to move onwards and be admitted, so therefore they're retained in the emergency department, causing an exit block of sorts. And not only does this affect leaving, it also affects patients entering the ED. These patients with severe complications also cannot ultimately get admitted and hit this impasse sooner during their care visit. So thus we can see that this is a multifactorial issue with multiple layers cascading on each other and compounding so that we see this presentation. And as we can all imagine, there are some ethical dilemmas to the situation. So first and foremost, privacy and dignity are violated. Privacy is defined as the freedom from unwanted exposure, whether that is your physical body or your information. So patients who are boarded, their private conversation with the provider are able to be heard by other people. They are exposed to the unwanted gaze of passerbyers, and this can really instill feelings of fear and self-consciousness in people, thus violating privacy and dignity. And additionally, beneficence is violated. Beneficence is the ethical principle promoting the most good for your patients. So, unfortunately, the cohort of boarded patients, from research we know now that boarded patients are at risk of poorer physical and mental health outcomes. They also have greater rates of leaving the ER without being seen. This is a very, very sad situation. And not only that, they have severe complications such as cardiovascular events and more anxiety, more depression, and poor outcomes. So this practice is not promoting the best good for patients if it places them in more vulnerable situations and causes them to be more susceptible to poor health outcomes. And lastly, existing health disparities are exacerbated from emergency department boarding. So the ED is unique in that it aims to provide nearly universal care access. It aims to help treat patients despite their ability to pay or their insurance status. So if we think about what kind of patients are relying heavily on these services, we can start to imagine these are our low-income, unhoused, and uninsured communities. And if we think about if these patients are waiting longer to get seen, when they are seen, they're getting lower quality health care. And after they are seen, they are at risk of worse outcomes. And this is a major issue. And we're basically exacerbating unequal allocation of resources, worsening existing health disparities, and not promoting health equity. So, some solutions to this issue. First and foremost, there are micro-level strategies to be applied directly at the level of ED. Some ideas suggested are getting fast-track pathways so that patients can see specialists quicker and reduce that lag time in the ED, as well as referring patients to outpatient centers and relying more heavily extensively on those services, as well as bolstering our urgent care centers, funneling patients coming into the ED for more minor cases and helping them see an urgent care provider and getting their needs addressed. And lastly, we have macro-level strategies. These are strategies applied at a broader systemic level at the hospital system level. One idea is to really prioritize reverse triage. This is when we triage patients already admitted, we do a thorough analysis of them, and we see if they're healthy enough to go home, and this will help free up inpatient beds for more patients. And another is implementing more robust post-discharge telemedicine. Oftentimes when patients leave the ED, they still have questions, they still have symptoms, so they might be prompted to return to the ED because they're anxious, they're worried for their health. So connecting patients with a provider via telemedicine can help reduce these anxieties, help get patients connected to providers to answer questions about risks, benefits, and alternatives of returning to ED, and thus providing more longitudinal care. And ultimately, through interdisciplinary collaboration and equitable interventions, we can work towards a more healthy and equitable future to help create better patient outcomes for all. Thank you.
Oh, we have a question. Yes. Please, Dr. Burke.
Yeah, Dr. Burke, good question.
If you talk to ED physicians, some of them would have the position that they should be able to turn people away and that it shouldn't be universal care. They would probably say this quietly.
Yeah.
But what would be your response to that?
I would say that it's we have to see the context of how patients are presenting to ED, and it's a little unethical to turn them away right at first notice. We have to see what they're presenting with, if they're frequent visitors, if they have a well-established history. And we don't have to turn them away from getting a room, but we can implement more like hot seat. Like at Regional Medical Center, there's a hot seat where patients talk to advanced care providers. If they have more minor complaints, they can talk to a nurse practitioner or a physician assistant and go to the hot seat rather than even going back behind there to talk to a attending. So I would say that we'd have to gather more information, get more context, and just make an ethical decision. Try to connect that patient with the provider at least before turning them away to just help improve patient outcomes and make sure we're not turning away someone who really needs help.
Any other questions? Thank you, Alex. Thank you very much for the question, Dr. Burke. So next we have Avi. with a very important topic about child abuse. Please help me welcome Haley.
Hi everyone, my name is Haley, and today I'm going to be talking to you about the misdiagnosis of child abuse in healthcare. So in 2009, in response to the growing recognition of hidden child abuse and neglect, the American Board of Pediatrics recognized child abuse pediatrics as a distinct subspecialty. These pediatricians would go on to practice a blend of medicine and forensics in order to diagnose a child's condition and its cause based on the analysis of medical imaging. Last year, in June 2023, there were 425 certified child abuse pediatricians in the United States. And although the jobs of these child abuse pediatricians are extremely important for helping diagnose child abuse in healthcare, although these jobs are super important, their immense power that goes relatively unchecked has resulted in a vast amount of trauma which has violated the physician's oath to non-maleficence. At the end of last year, the misdiagnosis of child abuse became a hot topic when Netflix released the documentary titled Take Care of Maya, which detailed the unfinished case of a young girl named Maya Kowalski. When Maya was 10 years old in 2016, she was admitted to the hospital with excruciating abdominal pain. Her parents tried to describe that she suffered from a rare neurological condition called complex regional pain syndrome, or CRPS, and that the only way to help the girl tolerate her pain was to give her a ketamine infusion. While ketamine is FDA approved for use as an anesthetic, it is more commonly known as a drug of abuse used for its hallucinogenic properties. Because of this association, a nurse was very concerned by the parents' request to give a young girl a ketamine infusion, and they alerted a child abuse pediatrician. Since there was no simple explanation for the girl's pain, the child abuse pediatrician concluded that her mother was either making up the girl's pain or causing it, which are hallmarks of a mental illness called Munchausen syndrome by proxy. The state took custody of Maya and held her in the hospital and cut off all communications between the girl and her family. When the blame and the pain of not being able to talk to her daughter became too much, Maya's mother ended her life. What the child abuse pediatrician did not detail in her case was that the young girl was already undergoing regular infusions of ketamine under the direction of an anesthesiologist who had been studying CRPS. Also, a clinical psychologist had met with Maya's mother and concluded that there were no symptoms of her suffering from Munchausen syndrome by proxy. In 2017, Maya was taken to see a professor at Brown University who was studying CRPS, and they agreed that she did indeed have complex regional pain syndrome and that the diagnosis of Munchausen syndrome by proxy was incorrect. Maya was returned to her father's custody, but unfortunately at this point, the pain and trauma to their family had already occurred and there was no way to reverse that. Cases like Maya's are not that uncommon. In fact, a study in 2018 found that there were 3.5 million reports of child abuse in America, but only 680,000 of those were ever actually confirmed by authorities. This huge disparity suggests that within the diagnosis of child abuse, misdiagnosis may actually be quite common. One of the biggest concerns when it comes to diagnosing child abuse is that these child abuse pediatricians have immense power that goes relatively unchecked. What they say is often taken as fact, and there's little secondary testing that is ever done to prove these claims. This is a huge issue because these people are not infallible, and like anyone, they can be guided by an entirely subjective gut feeling. They are also not specialists when it comes to a lot of the conditions that can present similarly to child abuse. Another huge issue is that the diagnosis of child abuse disproportionately affects socioeconomically disadvantaged families. Even though there is no ethnic or racial difference between the frequency of confirmed cases of child abuse, minority families are much more likely to be reported for child abuse. In fact, an investigation found that a child's injuries are as much as 9 times more likely to be reported as resulting from child abuse if that child is Black rather than white. In order to decrease the number of misdiagnoses of child abuse in healthcare, the investigation process must be entirely restructured. Each diagnosis should be considered by a multidisciplinary group, which includes but is not limited to pediatric subspecialists, which specialize in conditions that can present similarly to child abuse, clinical psychologists, which will examine both the patients and their families, and finally, child abuse pediatricians, which have the sole purpose of investigating a child's injuries and the family's explanations, and therefore they can devote more time to these investigations. During the investigations, they should ask questions such as, why do I suspect child abuse? Is there objective evidence of child abuse? And finally, is a dissimilarity between the family's values or appearance and my own affecting my decision? They should also have knowledge about past cases that they have worked on, as well as be debriefed if a mistaken diagnosis does occur, so that they can learn from past mistakes and also continue to be reminded of the weight of the decisions that they are making. As detailed by Maya Kowalski's case, a mistaken diagnosis of child abuse has the potential to wreak havoc on a patient and their family's lives. Innocent parents can be ostracized or wrongfully placed in prison, as well as lose large amounts of money fighting in court. Healthcare providers have the ethical responsibility to provide care that abides by the principles of non-maleficence and justice. In the case of child abuse investigations, they are currently failing this requirement and must correct their practices as soon as possible. They must correct their practices as soon as possible. By implementing the changes that I have outlined today, as well as continuing to improve the process over time, we can drastically reduce cases like that of Maya Kowalski's before more innocent lives are irreparably damaged. Thank you.
Wonderful, thank you so much. Yes, we have a question. You can come back. Thank you.
Like broken arms and stuff are pretty obvious, but neglect can be pretty subtle. And it can also have these socio-economic dynamics where if someone just can't afford to like buy fresh clothes for their kids, that might be construed as neglect. So how would your solutions apply to neglect?
I think it can be obviously super difficult to kind of see the difference between something somebody might like suspect it or even miss it completely, but I think that just the whole idea of having multiple people look at it is really important because they can all kind of weigh different things. Like a psychologist can listen to, you know, what the parents are saying, what the patient is saying, and really get a better grasp. I think the biggest issue right now is that they just, you know, these people have a lot of cases on their plate as well, child abuse pediatricians. And so they don't have the time to kind of, like you were saying, all these different things that might affect it, like how it presents or something like that. So they just don't have the time to really look into it. So that's how kind of what I was going with is that there's a bigger group that can really consider a lot of different aspects of the child's case, if that answers your question.
Yeah.
Yeah? Okay.
3 heads better than 1 head.
Mm-hmm. Yeah.
Great job, Haley. I just had a question. This is my first time hearing about Maya's case, but how did the child abuse pediatrician and the care team overlook the anesthesiologist's message? Did they not have access to her records, or was there a loss of communication? What happened in that scenario?
That's a good question. I don't think that they are entirely sure what happened there. I do think that they tried to show that evidence in court, but they didn't listen to it as much as they listened to the child abuse pediatrician. That's why I think that they just have a little bit too much power sometimes, because they listen to what they say more than other evidence that is shown in court.
Sorry, I have a follow-up. It's, for me as a mandated reporter, it can be really difficult because if there's any sign that pretty much anyone on the team construes as possibly being child abuse, it has to be reported and then they get sucked up into the system. So it seems like there's this upstream problem of who gets even referred. And in that situation, it seems like having more heads is actually worse, because anyone with any kind of bias or something could be like, oh, this broken arm could be child abuse, even though everyone else on the team disagrees it, because we're all mandated reporters in the hospital, then it has to be referred to CPS. Do you have any thoughts about how to fix that situation, or do you agree with my assessment?
Yeah, so I don't necessarily think that you don't want, a bunch of people being reported. I don't think that it's necessarily, as a healthcare provider, I'm sure you are all, debriefed on what to look for. So I do think it's not necessarily a big issue that it's pointed out if there are genuine concerns. But my concern is when it actually is taken as fact without really looking at the different sides of the story. So I agree that more people being there might result in more kind of red flags placed on patients. But if there is a genuine concern, I don't think that that's necessarily a huge issue, as long as the cases are looked at without. The whole purpose of having multiple people too is to try to minimize that kind of bias that somebody might have, that gut feeling. So I think that as long as more people are looking at the case, it's not necessarily a huge issue if people are genuinely concerned and reporting more.
Thank you so much. So next we have Sophia, with issues around egg donation. Thank you, Sophia, and welcome.
Hi, everybody. My name is Sophia Bouzid. I'm a senior biology and public health major, and today I'll be going over some bioethical issues associated with egg donation in the United States. So since the 1980s, oocyte or female egg donation has become an increasingly popular form of artificial reproductive technology. This is in part due to the fact that more and more women are choosing to pursue higher educational degrees, which is causing them to have children later in life. So biologically, between the ages of around 30 and 40 years old, women become increasingly susceptible to depleted ovarian reserves, the health of their eggs, and also ovarian damage, making it difficult to get pregnant naturally, which has exacerbated the need for healthy eggs on the market. So what creates a good donor candidate? According to many fertility and reproductive technology clinics in the United States, the ideal donor is between the ages of 20 to 30 years old, is in good physical and mental health, and is also capable of ovulating regularly. And although these are just some baseline characteristics that make a donor desirable, there are also a plethora of extraneous characteristics that elevate the donor's desirability. So what are some of these characteristics? Two of the most common are donors that have graduated from prestigious universities like Stanford, Harvard, Yale, and other Ivy League universities, and also donors that are conventionally attractive and or of a certain ethnic or racial background. So why can this act as a problem? When you have certain traits like educational attainment or physical characteristics, this is leading to the commodification of the human body, which is unethical in itself. Many egg donation agencies advertise the process as inherently altruistic, meaning that the intended donor is choosing to donate their eggs based on wanting to help a couple or a person experiencing infertility have a child. Although I think it would be naive to not consider the fact that many of these women being targeted as donors are pursuing expensive higher education. And so high monetary compensation, like as seen on this ad I found from a private donation agency, advertising $200,000 for a highly educated donor, and another offering a baseline of $40,000 for an attractive, diverse donor with desirable traits. This is definitely going to be an incentive for women who may have many student loans, or even lower socioeconomic women in need of financial help. So I think that this kind of poses a coercive undertone of the market. So there are various ethical issues associated with egg donation. The first one being a breach of informed consent and autonomy, which is the ability to make decisions free of coercive or controlling interference, and also having a complete or holistic understanding of the choices being made surrounding one's body. As I previously mentioned, the incredibly high monetary compensations, like up to $200,000 compared to the national average of between $6,000 to $10,000 for an egg donation cycle, could definitely lead to coercion when someone is thinking about becoming an egg donor. And then there's an issue of autonomy, specifically when it comes to fully understanding potential long-term risks of egg donation. Honestly, there is an incredible lack of research surrounding women's health issues in general, but especially long-term longitudinal studies focusing on risks associated with ovulation stimulation. So this also pertains to people that partake in IVF, but especially in young, healthy egg donors, they should be fully informed of any long-term risk associated with this process. And in one of the very few and most recent retrospective surveys, it was found that 55.2% of egg donors felt inadequately informed of these long-term potential risks, and 36.4% of the donors experienced short or long-term risks that they felt were downplayed by their providers. So I think that this statistic speaks to a potential inadequacy when it comes to providers giving a full picture of potential long-term risks. And then there's the violation of beneficence. So beneficence is the provider's responsibility to act in the best interest of the patient at all times. Now, of course, many providers are practicing beneficence to the best of their ability. There is not great research out there confirming possible correlations between ovarian stimulation injections and potential reproductive cancers or long-term hyperovulation ovarian syndrome, which, correlation does not imply causation. However, we cannot confirm or deny that these long-term risks exist. And so I think investing in better longitudinal research efforts is definitely a step towards increasing beneficence. But at the moment, I think the best that providers can do is, to the best of their ability, be giving a full picture of potential long-term risks. So some solutions. The first being market value regulation. So post-2011, the American Society of Reproductive Medicine actually did have a guideline suggesting a cap of $5,000 for egg donation compensation. However, they were sued by egg donors. The egg donors won, and that guideline has since been revoked. However, Spain actually has the second largest egg donation market in the world, and they do practice market value regulation, where every donor is compensated equally. And I think that this would definitely decrease the likelihood of coercion when it comes to monetary compensation, and is something that I think the US should adopt. The second solution would be to improve informed consent laws. So currently the ASRM has a set of guidelines that are just suggestions. They're not mandatory for providers to follow when it comes to how they inform patients about the egg donation process. And only a few states, including California, Arizona, and New York, have specific legislation that protects the informed consent rights of the patients when it comes to egg donation. I think that there needs to be a set of ethical guidelines that are used to create laws in order to make sure that patients are receiving all of the information necessary and not necessarily information that each provider individually believes to be important. And then the third solution I'm posing is improved longitudinal research. I think that there needs to be an elevation in both retrospective and longitudinal studies following egg donors, specifically people that choose to do multiple cycles. And I think that the improved research efforts will hopefully establish which long-term risks are valid and which are kind of just thought to be risks. And yeah, I think that this would definitely improve the informed consent process, autonomy, and hopefully the health of patients choosing to partake in this process. Thank you.
I'm just going to ask
Please.
is oocyte donation in Spain anonymous? And if not, is there any black market for eggs, or is there people skirting the system? Because I immediately thought of college sports and how like you can't pay them in the old days, but like they would get cheap cars and cheap apartments from fans of the team.
Yeah, so in Spain there is anonymity, so every donor is anonymously matched with a recipient based on the physician's perception of, does this donor have like similar phenotypic traits to the recipient, and that's pretty much the only criteria for match. And then the selection process is also very standardized, so there's that baseline level of like, are you healthy, are you ovulating, normally, and then like, is your mental health good, all of those things. But yeah, the compensation is standard, so I think that anonymity paired with standard compensation definitely probably perpetuates like recruiting people that truly have that like altruism and like they want to do this just for just to help someone and not because they need the money.
Do you think phenotypic similarity is an appropriate criteria?
So I don't necessarily think that it should be prioritized, but I do understand perhaps like the desire of people to have children that resemble them, maybe for a variety of reasons. But yeah, I don't think that it should be prioritized, and it's definitely prioritized in the United States, for sure.
Thank you so much, Sophia. All very fascinating topics, as you can see, and very important discussions of our time. So next we have Nick with drug rebates.
Hi, I'm Nicholas, and I'll be talking about the ethical implications of the drug rebate system in the United States. According to the U.S. Department of Health and Human Services, the United States spends $2.78 on prescription medications for every dollar spent by other Western industrialized nations. Now, given that clinical efficacies do not change across borders, this raises the question of what leads to such high prices that American patients face. Within the prescription drug supply and finance chain, there are multiple stakeholders, and one of these stakeholders are pharmacy benefit managers, or PBMs for short. PBMs are intermediaries between drug manufacturers, health insurance plans, and pharmacies where you would go to fill your prescription. PBMs are middlemen. They negotiate drug discounts from pharmaceutical manufacturers on behalf of health insurance carriers whom they are contracted with. These discounts manifest in the form of rebates, or small payments paid from the manufacturer back to the PBM once a medication has been dispensed to a patient. In exchange for rebates, PBMs will offer manufacturers a slot for the medication on something called a formulary, which is shown here. A formulary is a list of medications that a health insurance carrier will cover for their patients. These formularies are further subdivided into tiers, with higher tiers, medications on higher tiers, having lower co-payments for patients, indirectly encouraging their use. Conversely, medications listed lower on formularies will have higher co-payments, indirectly discouraging their use. Now, in theory, such a system should give an incentive to lower drug prices and spending overall. However, the exact opposite is observed. Negotiations between PBMs and pharmaceutical manufacturers first are protected by confidentiality agreements, which further obscures where savings are being realized. Number two, given that rebates are calculated as a percentage of a manufacturer's listed drug price, it is more likely that PBMs will only include higher price medications on their formularies. For instance, between a $100 medication and $200 medication, given that both drugs have the same clinical efficacy, the PBM will include the $200 medication, given that it would give them a higher rebate revenue. Now, through a series of horizontal and vertical consolidations within the PBM industry, this practice of negotiating rebates has only been safeguarded. As of last year, 96% of all drug claims in the United States are now managed by 6 PBMs. 10 years ago, this same market share was shared by 13 PBMs. In terms of vertical integration, PBMs have also merged directly with health insurance carriers, further blurring the line between health insurance plans and PBMs themselves, which further hides where savings through negotiated rebates might be realized. Now, this system of rebates leads to a number of ethical violations at the individual patient level. In a report provided as public comment to the U.S. Federal Trade Commission, it was reported that a $10,000 oncology drug was included on a patient's formulary, but meanwhile, its generic equivalent with a $400 copay was excluded, virtually blocking the patient from accessing life-saving medication. This not only violates a principle of autonomy in letting patients choose medications on their own free will, but it also violates beneficence, or the idea that we should be placing patients' health needs and their interests first and forefront. In two separate other studies, 32% of respondents reported reduced spending on a basic life necessity, such as food or rent, just to afford increasing medication prices. 12% of uninsured patients reported cutting pills in half or skipping doses to afford medications altogether. Not only does this violate equitable justice, but it also violates a principle of non-maleficence, or doing no harm to our patients, members of our society, or the most vulnerable patients within the United States. Now, how do we go forward from here? How do we resolve the ethical shortcomings of negotiated drug rebates? I believe that a hyper-focus on transparency is an excellent first step forwards. And transparency has been an emphasis of many private and public initiatives in recent years. In 2022, the Federal Trade Commission launched a sweeping inquiry and subpoenaed the top six PBMs, requesting formulary inclusion and exclusion data, as well as contract and negotiation data, dating back to the past 5 years. In 2026, in an aim to increase cost transparency overall across the board, Medicare Part D will begin direct negotiations with manufacturers for the top 10 most prescribed medications in the United States. I believe that a focus on transparency moving forward will not only ensure patients understand the true cost of their medications and drugs, but it will also ensure that medication access remains equitable, just, and follows bioethical principles. Thank you.
So one solution would be to like improve competition, and that seems to be the one you're suggesting.
Yes.
And one would be to abolish competition and have one entity that does this that's just highly regulated. What do you think of that solution?
I would say that increasing competition would be much more beneficial, as it would increase, in some sense, the transparency behind the negotiation between the PBMs and the drug manufacturers. In terms of having one entity do the rebate negotiations, that would probably be best done through the public sector at a federal level, given that they would be a government entity and they are ultimately responsible for that to citizens.
Thank you very much, Bilal. Thank you. Next, we have Joy. Welcome, Joy. And Joy is going to talk to us about the fitness industry and the ethical dilemmas. Thank you.
Hello, everyone. My name is Joy Peters, and today I'll be going over the realities of the fitness industry and the ethical dilemmas within it that impact health. So, in a world where we are bombarded by fitness influencers flaunting perfectly sculpted bodies and wellness brands promising enticing benefits, it's easy to get swept up in the compelling nature of the modern fitness industry. The problem is this industry is misguided by ethical dilemmas that actively work against the pursuit of individual health and well-being. And because of these ethical dilemmas, there is an incongruency between the industry and actual health and wellness. Even with a quick Google search of what the fitness industry is compared to health and wellness, we can see the stark difference between what these two images represent. So there's three main ethical concerns that I'll be going over today, with the first one being the commodification of fitness as a product. The fitness industry is a $30 billion business that encompasses everything from gyms to personal trainers to fitness nutrition brands. This industry operates within a commercialized market that often promotes monetary value over the actual pursuit of health and wellness. And many people buy into this industry. I'm sure we all have in some way, shape, or form. And we usually buy in to receive some sort of interest into health, but it's often misguided. We can see this with the rise of boutique fitness studios, like the ones pictured here. And this is creating a culture where fitness is synonymous with luxury, and associated with that is a whopping price tag that ultimately we aren't all able to buy into. Another huge moneymaker is the nutrition supplement market. We can see that these supplements, many of them, are not FDA approved and often lack conclusive research. However, marketers sell these as if it's a magic bullet to health. And this can be super alluring to the average consumer because, of course, we would want an easy fix to health, but this is just not accurate, and it's actually been found to provide an illusionary sense of invulnerability in which it promotes unhealthy choices instead, because you are under the impression that drinking a smoothie or taking a supplement is going to fix your health, so you don't take those active steps towards a healthy diet or a healthy lifestyle. And ultimately, we see that we can justify this monetary toll by believing we're investing in our own health, but the truth is health and wellness do not need to be expensive in order to be effective, like this industry may want you to believe. The next ethical concern is the misleading portrayal of fitness on social media. So the pursuit of fitness is often a difficult journey that requires dedication, and it's also imperfect. However, this is rarely bolstered on social media platforms. Instead, we see the image of perceived perfection. that like to leave people believing that it's easy to accomplish. And we also see the aesthetic of fitness bolstered most often, and not the reality of what fitness entails. So we can see this through mirror selfies or matching workout sets or those expensive smoothies. And we're lacking transparency of what a realistic journey actually looks like, which can be very difficult. It may not have linear progression or linear progress, and that needs to be made more aware. We can also see that there's some very real expectations that are not able to be met, that are being portrayed to the public. This screenshot comes from a YouTube video that has over 544 billion views. So a very, very widespread source of media that honestly I'm sure a lot of us have seen. And it's promising abs in 2 weeks by doing this 11-minute workout. And so this can leave the average consumer or someone who wants to fit into this ideal feeling very defeated when ultimately they won't be able to achieve this ideal that is being presented as something that is possible. Finally, our last ethical concern is the impending threat of misinformation, and the crux of this problem lies in the lack of universal credentialing within the space. There actually is no universal regulation for certification, and so at the end of the day, anyone can self-proclaim themselves a fitness professional, and that's very scary. It's actually been found that less than 20% of fitness creators online hold any necessary or reliable credentials or qualifications, and so especially if this is where we're getting our source of information, the threat of misinformation is huge. Also, we have some confounding factors within the fitness space where fitness enthusiasts can be driven by external factors like gaining followers, clout, or money, and they are missing the mark of actually promoting health and well-being. So this is another thing that can jeopardize the integrity of the information being shared. So ultimately, the fitness industry should be about promoting health and wellness, but as we've seen from these ethical dilemmas, that is not always the case, and in fact, we can see negative health consequences instead. The CDC reported that less than a quarter of the US adults actually meet the recommended standards for aerobic and muscle strengthening activities. So in this way, the fitness industry is failing a majority of Americans, and especially they're failing those who are unable to buy into the expensive market that it has become. And this gap in accessibility is leading to the fit becoming fitter, leaving the rest of Americans struggling to meet the basic standards of health. Next, we have social media, which is a big driver of this industry, and we see that there's an over-obsession with the physical appearance of what a healthy body looks like, but in reality, there is no one-size-fits-all model of what health looks like, and especially that's hard to gauge off of social media. A lot of it is interior and how your internal health and wellness is, opposed to just a perceived picture. And this engaging in this type of media can increase body dissatisfaction because there's an internalized weight stigma, especially the perpetuation of the thin ideal. And this can lead to dieting and increase the prevalence of eating disorders. And then lastly, with misinformation, the threat for physical injury is super big, whether that be you follow a tutorial from someone who maybe doesn't know what they're talking about and you get an injury working out, or in a more extreme example, there was a recent TikTok trend where they were dry scooping pre-workout, and these self-proclaimed fitness experts said that it would have faster acting results and lead to a better workout. However, they neglected to address the fact that that's super dangerous and can actually lead to respiratory and cardiovascular effects, which it did in some cases. So moving forward, there needs to be a big push to refocus this industry on health and well-being above all else. The nature of the current industry poses a significant public health risk. And it's super saddening because it's usually people that go out of their way trying to pursue a healthier lifestyle and they're taking the initiative to take steps to improve themselves, but they're getting met by falling into business traps, falling in or seeing things that are inaccessible to them that they can never achieve, or falling prey to misguided information. So instead, there needs to be a switch to prioritize health equity, challenge these harmful social norms, and to promote and advocate for evidence-based information to be disseminated. And ultimately, public health professionals can lead this cause, but it needs to be reinforced by the workers and consumers within the space to attach to the integrity of what they are trying to do, and that at the end of the day, it should be to improve health and wellness for all, and to take a more holistic approach to health, and to not get sidetracked by ulterior motives, and instead make sure the focus is improvement of internal health above other ulterior motives. Thank you.
So something happened in like 1990 where everyone started getting obese, and now the country's like 70% overweight or obese or super obese. So either everyone lost their self-control all at the exact same time, or something structural is going on. Do you think the solution to this has to be individual, or is there some structural solution?
Yeah, I think there definitely is a structural solution, and I think the issue that we're experiencing right now is a lot of people are going to social media, just seeing what's being promoted through these advertisements within the space, and they're going there to improve health, and that's not what they're receiving. So I think there definitely needs to be structural changes that can be spearheaded by public health professionals to give some more accurate information to greater audiences. I think it'll be especially impactful if some of these more day-to-day like creators, because people can naturally feel maybe more connected to them opposed to a healthcare professional if they also champion what these public health professionals are saying. And ultimately, I think that comes from having ethics. And if you're going to be in this space, you should be in this space to try to improve the health and well-being of everyone in your platform and the people who are listening to you.
So should we regulate free speech around it?
No, but I think especially if the majority of the people within the space can try to proclaim these things, it'll also give some power to the consumer to be able to distinguish what, like the hearsay from reliable data, because right now that's really hard. So I think the more that these people strive for ethical practices, the juxtaposition between them and some maybe lackluster, for lack of a better word, professionals, it'll be easier to differentiate. And then as a consumer, we can feel like more confident following who we want to follow.
Thank you. So next we have Bilal, with the ethics of brain death, an Islamic perspective. Thank you, Bilal. Welcome.
Good evening, everyone. It's good to see you all. Tonight I will be talking to you about the ethics of brain death from an Islamic perspective. First, I'd like to start us off with a story of a young boy named Ezzadine Mahmoud. In 2014, Maine, Ezzadine was playing outside with his brothers. He was practicing backflips, and he landed on his head. He was rushed to Maine Medical Center, where they determined that he had severed his brainstem, he had no pupillary response, and he could only breathe with the assistance of an artificial ventilator. Tragic as it was, the care team provided the best care possible, the way they knew how, and they presented his parents with a death certificate. His parents, however, were appalled. As Muslims, they saw their child breathing with a heartbeat, and they determined that, based on the Quranic lens, that he was not dead. Because in the Quran it states that death is categorically defined as the moment where the nafs, or the soul, leaves the body. The parents saw their kid lying there, and they determined for themselves that the soul had not left the body. So this conflict begs the question, does life end, and does the soul depart when the brain dies or when the body does? Now, many different Islamic jurists and bioethicists and scholars have debated this topic for decades now. And traditionally, it was easy. Traditionally, you saw the body begin to decompose in front of you when the person stopped breathing or their heartbeat stopped. And some scholars still follow this view. This is the first view, that's the more traditional one, that death can only be declared when the heartbeat and respirations of a person have stopped completely. Now, the second view here is that is more in line with the Western medical practice, where death can be determined by neurologic criteria. The basis for this is that some scholars determine the nafs to be entwined with personhood. And so if a person has no higher executive functioning or no cognitive function at all, then it's very likely that the soul has already departed, so death can be determined. Now, there is a third view as well, where scholars have determined brain death to be this transitory state of unstable life between the binary of life and death. And in this view, scholars are less concerned with declaring death and more concerned about the actions that we can take when patients are already in this state of brain death. And so in this view, scholars deem it permissible to remove life-sustaining treatment, but only declare death once breathing and heartbeats have stopped. So in a Western context, this presents certain ethical issues. So in the Islamic medical ethical framework, there is an emphasis placed on spiritual well-being that is not placed in the Western context. In Islam, mental, physical, and spiritual well-being are all intertwined, and a decrease in one can be supplemented with an increase in the others. And so for Muslims, when they're faced with great tragedies or illnesses, such as traumatic brain injuries, they may find it to be a trial from God or a punishment for their past sins. And so many Muslims turn towards prayer, supplication, and recitation of Quran to try to alleviate some of these burdens. However, the Western medical framework that we have does not accommodate for this, and so patients are often left to feel as though they are out of place, or that they do not belong, or that their actions don't belong in a Western medical setting. To this end, physicians to this end, their autonomy can also be undermined when physicians and other healthcare providers don't understand the beliefs and values that Muslim patients and their families come into the hospital with. This can undermine the physician-patient relationship, which is known to be important, and past studies have shown that a strong physician-patient relationship leads to better health outcomes. And so in order to maintain this relationship, I propose that physicians should use the lens of narrative ethics to understand the personal and religious backgrounds that patients and their families are coming from when they make these important medical decisions. In order to do that, physicians need to be cognizant of different cultural and religious frameworks, in that not every Muslim is the same, and every Muslim will find something to be important to them that may not be important to somebody else. I'd also like to talk about, I'd like to take a step back, because I understand that this is a niche issue, and talk about culturally competent care for Muslims in America in general. Post 9/11, Muslims have been painted as the common enemy of the United States and have faced a number of discriminatory behaviors against them. One that has been underlooked, though, is disregarding their beliefs and values in medical settings. Lots of Muslims feel as if, lots of Muslims believe that modesty and privacy are very important, and they prefer to be treated by same-sex providers. Modesty is also especially important when we consider the hijab for female patients. Other solutions to culturally competent care are to have an imam or a religious advisor on hand to help Muslim patients with the difficult medical decisions that they're forced to make within hours or days. And so by doing these things and by providing these solutions, we can work to create better, more culturally competent care for Muslim patients in America. Thank you.
So it's one thing to like respect and empathize with someone's cultural values, but should a physician be obligated to like act on those values? Like in the second formulation of NOFs, like where it was as long as they're, or maybe it was the first formulation, as long as they're breathing and their heart is pounding, some physicians would still say it's a dead body. Should they be obligated to treat the patient/body as a patient?
I think they should be obligated to at least consider it with the family and have that conversation with the family because it is their loved one who the physician is taking care of. And so with respect to physician autonomy, any physician has the right to say, no, I won't treat that patient. But in order to create the best care for the patient in the bed, I think they should talk to the family and have an open dialogue and use narrative ethics, understand where they're coming from and why they think the patient might still be alive before reaching a consensus on how to move forward. Yeah, Nicholas?
I'm just curious, but like, what happened with the patient who was after the chapter?
Yeah, so...
Could you repeat the question just for the...
Yeah, so the question was what happened to Azzedine after this conflict had occurred. And so the patients were, the parents were upset, and they actually consulted an external imam, a religious advisor, and they underwent a process known as ijtihad, where they basically consulted religious, legal, and medical advice on how to best move forward. And they did this for about 5 days because they were pressed by the hospital to make a decision. They decided that they would image Azzedine's brain one more time to see if there was any signs of life. And if there wasn't, they would pull the plug. But unfortunately, before they were able to conduct the imaging, his body gave out and he passed away.
Thank you so much. Thank you. So next we have Michael with the very important question of forced organ harvesting. Welcome, Michael.
Hi everyone, my name is Michael. I am a senior here at Santa Clara University, majoring in neuroscience and music, and I have a minor in biology as well. Today I wanted to talk about the issue of forced organ harvesting, which is a severe violation of patient autonomy and is known to occur in several countries for many years now. So to first define forced organ harvesting, it is the removal of one or more organs from a patient through means of coercion, deception, abuse of power, etc. And today I wanted to specifically talk about this issue in China because China has one of the largest organ transplantation programs in the world and is most infamous for past allegations of trafficking and harvesting organs as well. So we see here, these are some protests, and the people in these protests are mostly Falun Gong practitioners because, just to take you through a brief history of China's organ transplantation system, in 2006 allegations surfaced stating that the Chinese government was effectively murdering members of the Falun Gong, which is a religious movement that has been historically persecuted in China. And so these members are usually imprisoned, and as part of their imprisonment, they are generally subjected to forced organ harvesting, which effectively kills them in the process. And so this led to subsequent investigations by human rights lawyers, and they did come to the conclusion that these allegations were true, but not much happened in the aftermath. And so in 2015, China announced the change from using prisoners and their organs and switching over to a system in which only voluntary citizen-based organ donation was legal. And so these reforms they seem optimistic on the surface, but a number of concerns remain because of the lack of transparency and the lack of growth in China's organ transplant system. So first talk about the lack of transparency. Still with this new system, which is called the China Organ Transplant Response System, this is the program basically meant to fairly allocate organs to citizens. However, this system does not provide any information on where organs are sourced from. So organ allocation may be more efficient and fair to citizens, but we don't really have a way to confirm that organs are being ethically sourced from voluntary deceased donors like these announcements are proposing. The second concern comes from the growth of China's organ transplant program. So in the years after the 2015 announcement, China announced approximately 3,000 deceased donors. And currently, even China is considered the second largest organ transplant program in the world, only behind the United States, I believe. However, when we look at the public's willingness to donate organs, the Chinese public generally has a lower willingness to donate organs, which might be due to cultural and traditional values. And we see here with this statistic in 2022, China has an actual deceased donor rate of 3.9 donors per million people in the population, which is what PMP stands for. And this is among some of the lowest in the world. You can compare that to the US, which had 44.5 PMP in 2022, and Spain with 46 PMP also in 2022. And so both of these issues kind of raise questions as to how such a robust transplant program can be supported with low willingness to donate by citizens, low knowledge of organ transplantation, and low rates of deceased donors. And these issues are aware of in the international community and in the US as well. So recently in 2018, the China Tribunal convened to review evidence and witness testimonials to kind of do more research on the case of forced organ harvesting and to see if any crimes were committed by the Chinese government. Similar to the investigation in 2006, they did confirm that crimes against humanity were being perpetuated by the Chinese government, but unfortunately this tribunal does not have any legal authority. So any of its conclusions were just meant of a resolution for victims and their families. Here in the United States, we see several politicians that are championing this issue as well. Early last year, the Stop Forced Organ Harvesting Act was introduced, and this bill is designed to impose sanctions on those suspected of being involved in forced organ harvesting, and even allows the State Department to revoke any passports of those that might be committing these crimes. And we see also some politicians that are writing letters to the head of state, urging them to take action and urging them to press this issue along, because we know that legislation can also take a long time to take effect. And as an ending point of this presentation, I just wanted to talk through some of the few potential solutions that we can take as citizens and as more members of the community. The first is reducing the practice of transplant tourism. So transplant tourism is a phenomenon where patients that require organ transplants, usually from Western countries, travel to more underdeveloped third world countries to receive organs because they face much shorter waiting times, and they can usually find an organs very quickly at lower price points. And it's understandable that patients want to do everything in their power to ensure their survival. However, as future physicians potentially, or even patients who might need organ transplants in the future, we should be aware of how this can contribute to billion-dollar organ trafficking industries, and how this provides even more incentive for organs to be forcibly harvested from impoverished individuals, persecuted minorities, and prisoners. And so, looking at it from a medical standpoint, physicians do have the responsibility of informing their patients of how these procedures being done overseas can have lack of regulations and can lead to a greater risk of infection or health complications. And of course, these patients are pushed to resort to transplant tourism because of the glaring lack between organ supply and demand here in the United States, but as well as every other country around the world. There is always a lack of organs. And so they feel desperate, and they feel like they have to find these organs by themselves instead of just waiting on these long waiting lists. And there are many methods out there that offer a way of gaining more organs and making more organs available for transplantation. And one of these methods is called controlled donation after circulatory determination of death. And so this is a newer method, and it does require further research, but in this two-step approach, it's basically meant for deaths that are unexpected and occur outside of the ICU or outside of the clinical setting. And patients and their families would first be asked to authorize the process of harvesting and preservation of organs. And after families have had time to grieve and process their loss, then they are again asked to authorize the process of donation. So that gives them time to fully process their loss. Lastly, we need greater international accountability and coordination between countries because as of right now, there are limits to a nation's jurisdiction. There's no standard in terms of legislation regarding forced organ harvesting, transplant tourism, organ trafficking. And so things like the organ black market or those involved in organ harvesting, it's more easy to escape consequences just by moving across borders because of a nation's limited jurisdiction. So international committees like the UN Human Rights Council, the International Courts of Justice can offer more realistic plans that countries can put into place, and hopefully these legislations or regulations are put into place in a way that is coordinated across countries, and so we don't have to deal with those who are involved in these crimes just being able to move across countries and avoid any consequences. And so just as a last note that I wanted to leave you with, forced organ harvesting is a very grim issue and one that is difficult to come to grips with and even more difficult to solve. But from my research, it seems clear that we as a country and international community, we are aware of the different steps we need to take, and we are beginning to take those steps. However, later it is coming, but we know what to do. And so that gives me hope that we can address these issues as future physicians and lawyers and activists, and we can do these through accountability, compassion, and holding each other accountable for working together as countries and politicians as well. So, thank you.
There's this idea in behavioral economics that if you have organ donation as an opt-out process rather than an opt-in process, that more people would do it because they're too lazy to opt out. What do you think of that?
Yeah, I've heard that mentioned a lot too. On the surface, I think it makes a lot of sense. And I did do some research on that, and so far things seem that it doesn't make a difference just yet. So I'm not sure if it needs to be implemented on a larger scale to see results. But as of right now, some experts or some researchers have found that it hasn't made a difference just yet. But I think we should try it and see where it goes. It's worth a shot.
Do you know if there are any legal consequences of, say, like a United States citizen participating in organ donation tourism and then like traveling back to the U.S. and a physician finding out?
Yeah, as of right now, I don't think there are regulations in place where a physician has to report them or anything. There is another ethical issue that comes up for physicians themselves, like, do I treat this patient? Because some physicians might feel that makes them complicit in organ trafficking. And generally, the idea right now is that physicians have a duty to treat their patients. So it is their responsibility to treat those patients, even if they suspect them of having gone overseas. But if they don't feel personally comfortable, they can refer their patient to another colleague. But yeah, there's no legal ramification as of right now. Yes.
Can you say a little more about what do you think it is within Chinese culture that may be resistant to organ donation?
Yeah, in terms of traditional values, I'm not, I can't speak to that personally, but I can a little bit. But in terms of Chinese culture, I believe there is the belief that the body should remain kind of sacred. And speaking from personal experience, I'm personally Vietnamese, but we also have a practice of ancestor worship. And so we believe that our ancestors still come back and they're still with us in spirit in the home and things like that. And so going through the process of organ harvesting and donation might be seen as kind of not disrespectful to the body, but not taking away its kind of holiness and sacredness as a person and a spirit. So that is just more of my personal explanation. But I believe that is somewhat common in Asian cultures as well.
Fascinating topics tonight. Thank you so much, Michael. And so next we have Isa with concerns about the health of the incarcerated. Welcome, Lisa.
Hi, I'm Isa. I am a junior, double majoring in ethnic studies and political science. And I'm excited to talk to you today about ethics that operates under the prioritization of care and how that relates to my concern for the health of the incarcerated. So to start this conversation, we have to begin with an understanding of incarceration. The United States criminal legal system includes thousands of federal, local, state, and tribal prisons and other facilities. And in this, there are over 1.9 million currently incarcerated persons as of January 2024. The carceral state more broadly also includes definitions of surveillance, monitoring, and policing. Today, I'm going to focus on just the incarceration of people. And I think it's important to note the Georgetown Journal of Law and Modern Critical Perspectives affirms that the carceral state is a social, civic, and permanent death. So incarceration is a social determinant of health. Studies show that currently incarcerated people are more likely than the general population to have the following health issues, which is high blood pressure, asthma, cancer, arthritis, and infectious diseases such as tuberculosis, hepatitis C, and HIV. Other studies show that formerly incarcerated men and women also have worse physical health and mental health than the general population. In terms of physical health, this is related to the meals provided while incarcerated, so that a lot of them are energy dense and lack nutrition, but this also relates to things like aging while being incarcerated. And then also this goes back to the release from prison and what that means when you integrate back into society. Mental health is perhaps the most studied effect of incarceration, and this relates to the overcrowding, isolation, and stress that is endured while being imprisoned. And I want to highlight that obviously this creates disparate health outcomes along incarceration lines, but also race and ethnicity lines. This is because carceral mechanisms are overemployed for folks who are Black, Brown, and Indigenous. So not only is this because of incarceration that we have disparate health outcomes, but also this shows disparate health outcomes along race. Incarceration is also a public health crisis. I think it is relatively well known that the United States incarcerates more of its citizens than any other comparable country. But I think it's an understated issue, the impact of this on our national health. So in 2014, the life expectancy at birth in the United States was 78.8 years. You can see in more recent years, it goes to 77.5 and then 76.4. However, in 2014, some comparable countries like Spain, Sweden, Canada, etc., they all had over 81 years of life expectancy at birth. So there's studies that show that the incarceration in the United States leads to an overall average of about 2 years decreased in our life expectancy. And another study showed that for every 1 year of incarceration, that is 2 years off of one person's life expectancy. So all things considered, and thinking about mass incarceration specifically, I think we're left with two main questions. That first one is, should prisons be abolished? And the second question is, if prisons are not abolished, what can be changed? What can be done? What can we do? So in answering the second question, I think it would be remiss of me not to acknowledge some of the potential benefits or the arguments made for healthcare in incarceration. So some studies show that incarceration for some people who would otherwise have chaotic or unstable lives actually offers them regular meals, a schedule, and also some level of health care that they wouldn't otherwise receive. Other scholars also argue that with strategic public health planning, incarceration is an opportunity to scan for diseases and treat for specific infectious diseases that are really specific to many people who are being incarcerated and would not receive treatment otherwise. All that to say, though, my research continued to lead me back to the inherent harms of incarceration, despite those opportunities. So this figure shows kind of the different influences of incarceration and how continually it will lead to poorer health outcomes and ultimately to an early death. The thing about healthcare in prisons and jails is that the prisons and jails aren't necessarily equipped to operate and provide the same services that a hospital would. It just doesn't equate. So that brings me to some ethical decision making. As incarceration actually ensures seclusion and results in this early death, who's going to be left to care for incarcerated people? My research also led me to know that in a prison system, the healthcare provider and the patient are limited in communication and collaboration. They weren't meant to go together. So I want to focus on the care ethics lens. Early on in our internship, our cohort was discussing different ethical lenses. I want to focus on care ethics. And to me, care ethics stands on revolutionary empathy, and that leads us to this empowerment that kind of relieves those burdens of bias and fear. Studies showed that even the most well-trained healthcare providers, when trying to provide healthcare to incarcerated persons, required a change in their attitude toward their patient, which was the incarcerated person. Under a care ethics lens, which refers to our interdependentness as humans and our motivations and duty to act that is based off of not just kinship and intimate relationships, but being interconnected as humans, I think that leads us to being able to care for one another and move past these moral rules and kind of work into context-sensitive care. So I want to leave you with this statement that we, healthcare providers and community members alike, must expand our care for one another. Thank you.
So, abolish or reform? Where do you fall on that?
In short, as an ethnic studies major, abolish. And that requires a lot of, I think, context. I encourage you all to read abolitionist literature, but I'd say abolish. And a lot of that does start with creating conditions for abolition, and part of that is healthcare and healthcare equity.
So, I'll imagine a little scenario. I'm a taxpayer. I'm frustrated by crime. I don't want to pay anymore to help people who are in prison, even if they're sick. What's the ethical justification for for helping them? What would that be for you?
For me, it's based off of compassion. And like I said, I think care ethics has this context sensitivity that thinks beyond maybe criminalization and thinks about why is someone there in the first place. If their action that was criminalized was maybe not within their agency and in a way coerced, if we go back to ethics, I see in a lot of research that I've done kind of outside of this internship, but for more my interest in mass incarceration, I've found that oftentimes people are incarcerated for reasons that felt out of their control, for reasons that were preventable. So I think starting there is a way to kind of see through it.
Thank you.
I haven't read abolitionist literature, but from your research and your prior knowledge, what are some alternatives that those scholars are suggesting?
It's hard because there are a lot of answers, and it's really complex. A lot of it because we aren't necessarily in a place yet to abolish prisons. And I completely understand that. I think even in high school, if someone told me that abolishing prisons was the way to go, I wouldn't believe them because I was thinking about the fear of what would it mean to have a so-called criminal out in society, and what harm would that do to me? So I think a lot of the literature thinks about how do we create the conditions where we don't have that fear, or we don't have the actions that are criminalized. So whether that is addiction, or whether that is mental health issues that cause perhaps murder, things like that. I think going back to the root, I think one of our, I forget which guest speaker that we had, but talks a lot about going back to providing better like healthcare in early stages of life. I think that is part of getting to abolition, because then we are better persons in mental and physical health, and that means being better persons in society. I hope that answers the question, sort of.
I treat patients in jail for opioid addiction, and I struggle with the dual role of part of a system where I don't think these people should even be in, frankly, but they also need the help, and like through a care ethics lens especially, I feel like I'm almost obligated to do so, given my personal principles. Do you have any advice for me on how to navigate my dilemma?
Your dilemma being? I
feel that I'm working in an unethical system, but I also feel obligated to work with the group of people who need the help.
That's tough. Yeah, I think about this often because the system overall is unjust, right? But we have to keep going. I think you providing that care is already a testament to working against what is unjust in the system. And so long as we have prisons, I think if we operate to the best of our ability, that is still important, and that providing that care is necessary, and that if that's what has to be done until the system is more just, then that's a good thing.
Thank you very much. So our next speaker is Tatyana with a very important topic about Hawai is no paradise for healthcare. Thank you, Tatyana, and welcome.
Hi guys, my name is Tatyana. I am a senior majoring in biology and neuroscience with a minor in Japanese. And I chose this topic because being born and raised in Oahu and on the pre-med track, I've been told some form of, that's awesome because Hawaii needs more physicians. However, it wasn't until recently that I truly grasped the significance of those words. So to start off, Hawaii has been in the healthcare crisis well before COVID-19 and the more recent Lahaina Maui fires. And these challenges are further exacerbated by the island's geographical isolation about 2,400 miles from the mainland. And to talk more about the Lahaina Maui fire, this occurred on August 8th to 9th of 2023, and the devastating fire demonstrated the deficiencies in our healthcare system, as there are only 3 healthcare clinics serving approximately 30,000 patients. And despite Hawaii having a low uninsured rate, this does not equate to the access or quality of care, as we are currently in a shortage of about 800 full-time equivalent physicians, and this is partly due to lower pay and state taxations on medical services. For example, Hawaii is only one of 2 states that taxes medical visits and the only state to tax Medicaid. Additionally, Hawaii has the fewest hospitals per capita, and they also have the 10th longest wait time in emergency room services. And these directly translate to prolonged delays in care for many residents, often necessitating them to go to travel within inner islands, which can also be difficult financially. And even then, on outer islands, many hospitals only serve as community-based clinics with limited subspecialty care. And also another challenge that's unique to Hawaii is that we are known as the most culturally and racially diverse state in the nation, with 1 in 4 residents speaking another language, Communication hurdles are common amongst those with limited English proficiency, and I've also witnessed this through family members, and this language barrier often results in poor quality of care, unequal treatment due to impatience and lack of cultural competency of healthcare workers. And I also wanted to focus on Kanaka Ma'auli, which means Native Hawaiians, as they are the most disproportionately disadvantaged from these inequalities. And today, only 47% of them still remain in Hawaii, and that makes up about 21% of our population in Hawaii. But to start to even address some of these inequalities that Native Hawaiians face is to understand the cultural, historical trauma and ongoing colonization that exacerbate these inequalities today. So just some brief background. The first contact with the Western world was in 1778 with Captain James Cook, and with his arrival, the diseases like measles or chickenpox decimated the population by about 90%. And then this also led to missionaries who imposed Western culture and religion through things such as boarding schools and forcibly removing Native Hawaiian children from their homes. And then consequently, in 1893, the Kingdom of Hawaii was illegally overthrown by a small group of businessmen who invaded Iolani Palace and forcibly removing Queen Liliuokalani from the palace. And then this also further eroded Native Hawaiian rights and traditional practices and the near extinction of Hawaiian language. And then today, this is reflected in Native Hawaiians having the highest COVID cases and death rates in the US, and where in Hawaii, 15% of them are uninsured. Additionally, they have the highest poverty rates and shortest life expectancy, about a decade shorter than other ethnic groups. And they also have the highest mortality rates of cardiometabolic diseases such as diabetes, hypertension, and cancer. And this is due to Native Hawaiians often being unaware or undiagnosed of their conditions due to culture and language barriers, and also just the lack of access to care. And then going for future directions, I think it's important because I believe a statistic stated that today with healthcare data, 30% fail to recognize Native Hawaiians as they're often grouped together with the broader Asian categories. So it's important moving forward to properly disaggregate other under-recognized groups as well. And I wanted to highlight a community-based program called Kula na Napoe Hawaii, which is specific to helping Native Hawaiians, and it shows the value of integrating cultural practices and tradition in healthcare to promote health literacy and also their overall well-being. Yeah. Mahalo nui loa.
A lot of the land in Hawaii is still owned by like less than 50 families that were around in the 1890s. So the imperialist legacy is still very much alive. How much of the solution do you think would come from breaking that legacy up even more than it has not been really?
I think it's very beneficial because even today there are a lot of protests and under-recognition for Native Hawaiians. Like often you see now, the more recent and popular was like this telescope being built on Mauna Kea, and many Native Hawaiians like were protesting against that, but of course like authorities were like trying to shut that down because of course technology is important for advancing our society, but it's also important to acknowledge and respect cultural grounds and their practices, and also returning some of the land that was illegally taken from them.
Yeah, I'm fascinated by, the 3.6% uninsured is kind of amazing.
Mm-hmm.
And like, what accounts for that? Like, is it a statewide insurance program? Or
yeah, there's a lot of, I think it's unique to Hawaii, but there's a state mandate that employers have to provide health insurance for any workers that work more than 20 hours a week. And this is also to help the fact that we have a very low minimum wage. I believe it just got up to like $12 now. So yeah, that's why the policies like that were implemented to provide health insurance, even for like, I believe even like McDonald's, they provide it for at least in Hawaii. Yeah, any jobs.
Yeah, it's just, it heightens the tragedy with that kind of insurance coverage, but yet the problem of just lack of medical practitioners.
Mm-hmm. And also shortage of like subspecialties within that too.
So if someone's diagnosed with, I guess, like an illness that's treated generally by specialists, do they typically fly out from Hawaii, or do they receive care like within Hawaii?
It depends on the severity of it, but oftentimes it's the residents who have to fly out to here to receive help, and I think it's mainly only like huge surgeries that people from the mainland fly to Hawaii to help out. Yeah, Nicholas?
What are some of the causes of the physician shortage in Hawaii itself?
Sorry, what was the first part?
What are some of the causes for the physician shortage in Hawaii?
Sorry.
What's the causes of the physician?
Oh, the causes? A lot of it is just the low pay. Like, it's very difficult for physicians to first establish a practice with the amount of regulation in Hawaii to even get a license, but also with like the taxation on medical visits, it's hard to make. I believe they're paid a lot less than here on the mainland, but that also just like doesn't really encourage other like students now to pursue medicine, and there's also a lack of opportunity even if students now wanted to pursue medicine. Like, it's really hard to get internships back home. That's why a lot of people move to the mainland, and even we only have one medical school in Hawaii, and even then, like, it's not guaranteed that students who go there will stay.
The salaries are a lot lower than in California. When I was looking for jobs there, they're like $100,000 less.
Thank you very much, Tatyana. So our next speaker is Kate, and she's going to talk about the impact of gender-affirming care restrictions on healthcare providers. Thank you, Kate. Welcome.
Hi everyone, I'm Kate. I'm a senior public health major with minors in biology and Spanish. And today I'm going to be presenting on transitions in turmoil, the impact of gender-affirming care restrictions on healthcare providers. So as I'm sure many of you are aware, transgender people on a global scale experience major scrutiny and ridicule, discrimination, violence, and systemic barriers that prevent them from being able to live authentic, true lives and being able to survive and thrive on their own terms. And one resource that is critical to their well-being that has recently been impacted significantly has been access to gender-affirming care, particularly for transgender adolescents and youth. So in 2021, Arkansas became the first state in the U.S. to create an restriction on gender-affirming care, and in the 3 years since, there are now 25 states in the U.S. that have restrictions on gender-affirming care access for transgender adolescents and youth. So even just within 3 short years, now 39% of transgender adolescents in the U.S. do not have access to gender-affirming care, and this is equivalent to approximately 150,000 people. So a little bit about gender-affirming care. So it refers to a range of psychological, behavioral, social, and medical interventions that best support a person's gender affirmation, which typically contrasts with gender identity assigned at birth. And medical providers can be involved in any of those forms of gender affirmation, but if you want to speak specifically to medical interventions, that includes hormone therapy, speech therapy, counseling and psychological services, hair removal, and also surgery as well. Within gender-affirming care, it is universally regarded as life-saving, as medically necessary, as best practice medicine, internationally and nationally, so amongst dozens of other organizations. The American Academy of Family Physicians, the American Academy of Pediatrics, the American Medical Association, the American Association of Public Health, and the American Psychiatric Association all confirm gender-affirming care as best practice medicine. And physicians are morally obligated to endorse best practice medicine to provide that to their patients. If they're not able to, they're directly contrasting their obligations and their professional oaths to the patients. Just to go a little bit into gender-affirming care restrictions and the impact on physicians specifically. So currently 23 out of the 25 states that have restrictions on gender-affirming care impose specific professional or legal consequences on physicians who prescribe minors with gender-affirming care. So while there's a lot of variations across state lines regarding what specifically those consequences are. Some of the common ones include disciplinary action from state legislator boards. It includes civil suits, loss of medical license, and even felony charges with potential prison or jail time. So some examples, in Alabama, it is a felony to prescribe a minor with hormone therapy or puberty blockers with potential prison time. And in Utah, it is illegal to aid and abet a minor from accessing gender-affirming care. So again, while there's a lot of variations, there is the potential for loopholes or finding ways to work around those laws. But a lot of physicians are now just stopping prescribing gender-affirming care in general or providing that to patients because of fear of liability or fear of the consequences that could result from them providing that care to those people. So maybe if you aren't able to provide a minor with gender-affirming care, maybe you still want to maintain that relationship with them, but you're not able to provide this life-saving care that's critical to them. In regards to some of the ethical implications of blocking gender-affirming care from being provided by primary care providers, it directly violates professional obligations to provide best practice medicine from providers. So as I mentioned, it's universally considered to be best practice medicine. It directly contradicts beneficence, non-maleficence, and also respecting patient autonomy and patient decision-making regarding their care. So many patients who go into healthcare clinics seeking gender-affirming care, they're very aware of what they need, they're very aware of their gender identities, and they know that this is the best source of treatment for them. And them being denied it is in direct contradiction to them knowing what's best for themselves. It also violates the ethical implications of doing no harm. So rescinding gender-affirming care from people can have immediate physiological and immediate psychological implications for patients. There's a reason why 40% of trans youth have attempted suicide, and there's significant reasons as to why there are other major mental health and physiological health disparities in the trans community, and a lot of that is due to limited access to healthcare as well. It also compromises patient-provider relationships. So like I mentioned, if you're a patient going in to see your provider and you're no longer able to access that care that they were giving you before, it rocks the boat of that trust that you've developed with this provider, and it also breaches the potential for confidentiality as well. Physician quality of life is also something that has been increasingly catching the public's attention, and the implications for stress and mental health repercussions on physicians who are no longer able to provide this care that they have been doing for so long. They've trained for a significant amount of hours and developed these really solid relationships with their patients, and them no longer being able to provide that care that they know is best practice medicine can be deeply distressing to talk to their patients and tell them, I can't give this to you anymore. I know that you've been relying on me for this, and I can't give it to you anymore. And there's also just the general stress of potentially losing your license if you do what you know is best for the patient. There's a potential for even jail time or even just uprooting your whole life. And now physicians are faced with a lot of really impossible decisions to make and really insane ethical challenges that they have to discuss on a regular basis. So maybe you're considering leaving the state in order to practice medicine in a way that you know is best, but that means uprooting your life, saying goodbye to family and friends in a region that you've grown to love. It means saying goodbye to patients who trust you, and even if you can't provide them with gender-affirming care, you're saying goodbye to that trustworthy relationship with them too. Maybe you still try to provide gender-affirming care to a patient, but you're risking losing your license. Maybe you try to recommend another provider to your patient, but that also puts both you at risk, your patient, and that other provider who now is going to provide that care. So there's just a series of ethical dilemmas that physicians every single day are now faced with in half of the states in the United States now. And moving forward in terms of what we can do, within 3 years, we've already seen half of states having these restrictions, and since so much of this is moving on so quickly, there's been a lot of overnight changes in physicians basically having to change their practice immediately. One thing that's great is that a lot of human rights organizations and individual plaintiffs consisting of transgender people and their families, and also healthcare providers who provide gender-affirming care as well, are challenging these bills in court. They're challenging this legislation and winning in some cases. A number of appeal courts are ruling in favor of the plaintiffs and are ruling in favor of providers on behalf of discrimination and privacy clauses. But at the same time, these bills are continuing to be passed and continuing to be proposed in legislation. Just 2 weeks ago, South Carolina became the 25th state in the US to pass another restriction on gender-affirming care, and it doesn't look like that's the end in sight anytime soon. So In the meantime, while these bills are being challenged in court, support networks for physicians and for trans people to be able to access life-saving care and the resources that they need to survive and thrive is really, really critical. And just as the general population, all of us have the ability to work in securing social justice as well. So as we enter Pride Month, I really encourage all of you to find some way to get involved, show your solidarity, even if that's not necessarily related to the trans community or related to gender-affirming care. Pride is not just a celebration, it's a protest, it's a movement, it's an ongoing active movement for social justice and equity for everyone. So even if that's contacting representatives, getting involved in parades or protests, or even just talking to your LGBTQ plus friends and family, neighbors, coworkers, peers, strangers that you interact with on the street, we all have the power to make a change and all have the power to get involved in some way. Even if it's just like paying attention or listening and tracking. Kaiser Family Foundation is consistently keeping track of this, so even if you're just paying attention to the news, checking in on your friends and family, it goes a long way. So, thank you.
How possible do you think it is to have something like access to telemedicine to get these gender-affirming treatments like hormone therapy? Is that still legal or not?
It depends on the state. So some states have written in clauses that you can't seek outside state care, which is really obscene. Some states just have really vague written, clauses that just say like, oh, you can't have access to gender-affirming care. I know for some people in certain states, I don't know specifics, but telemedicine is an option, particularly within state networks where maybe like a doctor in California is able to consult with a doctor in Arkansas or a doctor in Kansas and talk to them about these options. I think for some people for telemedicine, like it's probably more accessible for maybe a person who's like going to college or from another home state and they're working somewhere else. And yeah, it's really complicated, but.
So in the last month or so, the big report came out of the UK, the CAS report about gender-affirming care, and it there found that the literature was quite ambivalent on its benefits, or more ambivalent than perhaps we let on here in the US. I think they've restricted some gender-affirming care there or put brakes on it. Mm-hmm. What's your response to that?
I mean, I think you can just kind of talk to a trans person, like particularly a trans youth, and you can see, like we talk about gender dysphoria, but gender euphoria is really real as well. To have your identity be affirmed and to have it be, to just feel at home in your body and feel secure and safe in who you are, and to be affirmed by the people around you as well is really important. But I think anecdotal evidence to me like that at the end of the day is most powerful. I think the UK in itself is also seeing a lot of resurgence of anti-trans and in general anti-LGBTQ plus sentiment that we're seeing in the United States as well. If you look at specifics regarding gender-affirming care, I know that regarding like surgery rates, the regret rate is less than 1% in terms of people who had those surgeries and either regret that procedure or don't. It's the vast majority of people feel content with their decisions and feel content with those choices. Yeah, I'll have to look at those results, but
thank you. Yeah. Thank you so much.
I have an additional comment too on that topic. Like, if not gender-affirming care, that leaves either doing nothing or conversion therapy. And there was a paper out of MGH that showed that conversion therapy increases suicide rates in people who have experienced it. And it was a very large study. I think it was over 10,000 people who had experienced conversion therapy. But anyway, my question for you is, do you see a role for civil disobedience by doctors in this situation?
Absolutely. I think provider perspective is probably, after trans people, the most impactful voice that we can listen to at this time and the most impactful voice we can center at these conversations. You see, if you're paying attention online, you can see lots of videos of providers going to these state legislatures and giving their testimony and declaring what they're seeing and giving their perspective on what's critical for their patients. I think, like I mentioned earlier, physicians and healthcare providers have an obligation to stand in solidarity with their patients, and trans people are some of the most marginalized people in our society today. And if you're able to provide that voice to your patients, stand in solidarity with them, it also just continues to strengthen the patient-provider relationship as well. And it feels great to see maybe your own physician or someone in your community standing up for you and standing with you. I think physicians and providers absolutely should be involved if they can.
But should I illegally treat people for it?
Oh, sorry, I misinterpreted your question.
Oh, no, I was vague.
Yeah. We had the opportunity to speak with Dr. Spielvogel, who is a physician in Sacramento who treats trans patients regularly. And I think for him, or at least he kind of brought up that same issue of, for particularly a young person who might be grappling with severe mental health repercussions of not having gender affirmation and the repercussions that can happen from not having that. I mean, what's good is that so far I don't think we've seen anyone actually like jailed or imprisoned for violating these laws, and a lot of that has to do with, these are being challenged actively, and it also requires like someone else to report on the physician or report on the patient who's seeking that care. And it seems like a lot of people are standing in solidarity with their peers or anyone else who they know who might be trans who is seeking that care, or providers who they know are providing that care. It's hard for me to tell a physician, like, violate the law and you have the risk of losing your license and losing your practice or going to prison, and then you're not able to practice medicine at all. And then, it's hard for me to say. And I don't want to, having no medical expertise, it's hard for me to say.
Obviously, like, adolescence is a time when the body's undergoing a lot of physiological changes. Mm-hmm. That's kind of like a two-part question. One, are there any negative consequences to adolescents receiving hormone replacement therapy, like, during that time? And, like, if not, like, if there are not severe consequences, like, what is the biological evidence that supports, like, these legislators to make these laws that restrict people from getting gender-affirming care?
Yeah, so regarding the first part, in terms of like hormone therapy and puberty blockers, to my knowledge, are reversible, and hormone therapy is somewhat reversible. So in terms of like biological repercussions, I'd say there's not too many. And for a lot of trans adolescents who go into these clinics asking for additional care, physicians hopefully are being really transparent with them about all of the risks and benefits that come with these medications and that come with these treatment options. And also patients and their families as well are doing this research and also weighing the risks and benefits. In terms of what biological evidence is influencing like these legislatures, a lot of it isn't. These laws are made by people who don't have medical expertise or do not have a background in trans medicine specifically. And you can see kind of general trends as to where this is happening in certain states. It's another major, like, it correlates with a lot of the restrictions we're seeing on reproductive health care as well. Much of that is connected to resurgence of, like, religious extremism and anything that goes beyond, like, the traditional family unit or traditional gender norms is seen as a threat to general society. I don't really have an answer as to like what evidence. Most of it is like a protect the children sentiment, and the idea that anyone who's under 18 can't think for themselves, or that this treatment is dangerous. It's not. It's life-saving and it's necessary. I hope that answers your question.
Thank you very much, Kate. Thank you. So our next speaker is Addison, and she's going to talk to us about the denial of Tubal ligation access in Catholic hospitals. Thank you.
All right, so hello everyone, my name is Addison. I'm a sophomore here at Santa Clara studying biology and environmental science with a minor in public health. And today I'm going to be talking about how we deny patients access to tubal ligation in Catholic hospitals. So the first thing that's important to explain is what the ethical and religious directives for Catholic health services are, also known as the ERDs. Just remember this because I'm going to bring it up later. So what we're focusing on here is specifically Directive 53, which states that sterilization procedures are only allowed in the case of often a life-threatening condition and there is no other way to treat it other than sterilization. Any other situation is not allowed, including if they would die if they got pregnant, is not considered a reason actually to sterilize someone because they can just not have sex. And essentially, the ERDs are the rule book for Catholic hospitals. So they're generally considered guidelines, but in most cases are never violated. And so just a little bit of background on what tubal ligations are. So they are a permanent sterilization procedure. They're 99% effective at preventing pregnancy. They're non-hormonal, which is one of their very unique traits, as well as the fact that they also reduce the risk of ovarian cancer. And the important thing to note about tubal ligation procedures is that 1 in 5 women do this procedure during their lifetime. So this is a really big thing that we're talking about here. I know that many of you probably haven't even heard of it, but this is actually a really big deal. And something that's important to consider here is that the market share of Catholic hospitals in our healthcare system is rapidly increasing. So about 30% of American women now are living in areas with high or dominant market share by Catholic hospitals. So that means that as their market share continues to increase, we're going to see increased restrictions and decreased access for women to these very vital procedures. And so one of the 2 biggest issues that I came across during my research were, 1, a lack of transparency. So only 24% of Catholic hospitals disclose on their website that the ERDs even exist, which is a huge problem. If you're a patient and you're looking for healthcare and you have no idea that they're restricting actively your access to reproductive healthcare, you can't make an informed decision as a patient. Something else that's important to know is that now we're dealing with huge lack of access, and this is super inequitable because, first of all, maternal mortality in the United States is a huge issue. And it's incredibly inequitable as it mostly impacts Black and Indigenous women, which is something that's very important to consider, as well as the fact that many Black and Indigenous women live in areas where there are only Catholic hospitals. This is not only violating patient autonomy because we are restricting actively patients' access to a necessary healthcare procedure for reasons that are non-medical. So it's not because it's dangerous, it's not because you're going to die if you get a sterilization, it's entirely for a religious purpose, which is infringing on a patient's right to choose what happens to their body. And if you don't have a healthcare reason, if you don't have a medical reason to say no, then now we're getting into, okay, what's the balance between religious freedom and the autonomy of your patient? And something that's important to know here as well is that pregnancy is not health neutral. I know that we often think of it this way as, oh, you're just pregnant and then you'll give birth and you'll be okay. But not only is maternal mortality a huge issue, but you're far more likely to become depressed, be anxious. You're actually 35 times more likely to be murdered while you're pregnant and postpartum. So things like this, there are a lot of social consequences as well to being pregnant that are important to consider. And so there are 3 big solutions that I considered deeply in my piece. So the first of all being that Catholic hospitals absolutely have to be disclosing the ERDs and how these are affecting their policies. So if you're a patient, you have to be able to know when receiving healthcare from a physician how the policies at the hospital are impacting your access to care. So currently, only about 30% of American women who primarily seek healthcare for reproductive health specifically at Catholic hospitals are even aware that their hospital is Catholic. So that's a huge issue. If you don't know that your healthcare is being impacted and they don't tell you that openly, why would they? Then all of a sudden you're having your right to choose what happens to your body and the healthcare you receive being impacted without your knowledge. Also, I think Catholic hospitals, if we're talking about reducing the changes to policy in general, the best way to do that would be to refer patients to non-Catholic hospitals. However, there are a few really big reasons why this isn't exactly the perfect solution. So first of all, being that in the ERDs, it specifically says that hospitals cannot promote or agree with sterilization procedures, pretty much unless there's like the threat of death. So referring patients gets really complicated because then you're in a gray area of, are they allowing patients access to it, but just through other means? So this is getting into a bit of a gray area here, as well as the fact that tubal ligations are the safest to perform during cesarean sections. And so if you have patients who are getting a cesarean section at a Catholic hospital, now you're subjecting them to another major procedure that would be entirely unnecessary if they were able to just get that procedure at the same time as they're getting their C-section at the Catholic hospital. As well as the fact that you're dealing with issues of insurance. You have patients who are richer who are able to go to a non-religious hospital and maybe go out of their healthcare plan, and they can pay for it out of pocket. And then you have all of your patients who are in rural areas who can't afford to go all the way to a different hospital, who now have entirely no access to a vital healthcare procedure. And the more effective way that I think would be to overthrow this policy without actually allowing tubal ligations is just to allow women access to temporary contraceptives. This is something that's also not well known, is that Catholic hospitals also do not allow the use of contraceptives for the purpose of pregnancy. It's entirely unallowed. In fact, the only people who are allowed to have access to it are for literally any other reason. So you can lie, but not everyone knows this, and they're not going to actively offer it to you. So if we were to just do that small thing, if we were to say, hey, if you need it to avoid being pregnant, then you can have access to contraceptives, we would be dealing with a lot less issues in terms of the ethical implications of completely banning tubal ligations. So yeah, that's essentially everything that I have for you today. And just, yeah, important to remember that just because we aren't hearing about it in the news doesn't mean it isn't affecting a large portion of our population. Thank you.
Do you know if Catholic hospitals perform vasectomies?
Same restriction, actually, yeah. So Directive 53 is for females and males. It doesn't matter what, unless it's basically life-threatening, you have no access to sterilization. Yeah.
Yeah, so, great talk, Addie, but so Directive 53 isn't told explicitly to patients. Is it told to physicians who are onboarding or start to work at these hospitals? Do they know what they're getting into as well?
Absolutely, yeah. So, I mean, physicians have to know because they cannot offer something to a patient that they physically cannot perform. Something that's really important to know here, though, is that especially when we're talking about sterilization procedures and tubal ligations, which are often performed within 48 hours and mostly at the same time as C-sections, we're relying entirely on patients' access to a non-religious hospital that's near their house. So when, obviously, if your patient is in labor, you're not going to drive them over state lines or somewhere else within, multiple hours away to go get health care and guarantee that they can be sterilized during that process. So they have to stay nearby. And that's where the issue arises of, yes, physicians know, but they aren't obligated to say anything. And so you're relying on physicians being open with their patients. And so obviously then you're kind of relying on the goodwill of people. And if they don't agree with tubal ligations, why would they say, oh, you can go to a different hospital and get it done? There are just a lot of issues there, as well as the fact that, once again, they can't promote sterilization. And so a lot of hospitals, that would be looked at as infringing on that. You can't say, hey, by the way, if you go down the road, you can get this procedure, because then you would be actually promoting it to your patient. So they could get into a lot of trouble for that. Yeah.
Is it ever justifiable to compel a physician or really anybody to act against their religious convictions?
Oh, absolutely not. And this is a conversation, I bring that up in my essay. Doesn't really have time for that here, but yeah, like you cannot and should not force anyone to do something against their will. And physicians have a right to autonomy as well. This isn't about forcing physicians saying, hey, I know that your religion doesn't agree with this procedure, but now you have to do it. The biggest issue that we're finding is that many physicians actually disagree with the policy and are being forced now to not perform it when they're fully willing to do so. And so now we're running into the issue of we could do it, and the physicians are fine with it, the patients are fine with it. So who are we really benefiting? Yeah.
Thank you very much. Our next speaker is Anna with a talk around substance use disorders. Welcome, Anna. Thank you.
Hi, my name is Anna Ketchum. I'm a neuroscience and public health major, double major with a minor in biology. And today I will be talking about substance use disorders and how we can place emphasis on confidentiality and autonomy through recent legislative changes. So I've included some statistics and some charts in here for just recognition of the national crisis that's currently going on. Nearly 47 million individuals aged 12 and older currently struggle with substance use disorders. So it's really important to note that these are obviously from 2021 and 2022, and the use of illicit drugs went up 26% from 2021 to 2022, and substance use disorders only went up 1% from 2021 to 2022. And researchers have found this very interesting because they think that the use of illicit drugs could be the legalization of marijuana across the country, and also people struggling with their mental health during the pandemic. The reason I bring the use of illicit drugs up in this conversation is because people that have mental health disorders are more predisposed to substance use disorders. And there is obviously an ethical discussion on mental health disorders and the intersection with substance use disorders. I would also like to note the top reasons for people not getting treatments. Just to clarify, SUD stands for substance use disorder, and AMI stands for any mental illness. So a lot of people thought that they, over 3/4 actually, thought that they could handle it themselves, or they just weren't ready to receive treatment. So I think that this is really important because I'm going to talk about stigma later on that is very impactful to people in the United States struggling with this. So recently, it was February 8th, 2024, there were changes to 42 CFR Part 2 that is to align more with HIPAA, and it ultimately is advocating for the confidentiality and autonomy of those struggling with substance use disorders. So one thing that comes from this is that you're no longer allowed to use records of those that have received treatments or diagnosis of substance use disorder in court hearings unless the individual is okay with obviously that being displayed, or if there's a court order for it. And it also aligns with, like I said, HIPAA, because HIPAA has a part of it where it says people for psychotherapy, the confidentiality of the notes and things like that weren't being as applied to those receiving therapy for substance use disorders. So it's been a really important thing that happened just 4 months ago, which is really interesting. So I'm going to talk about utilitarianism and the importance of it in this issue because obviously it has to do with the overall good for the population and doing the best for your patients. And then I would also like to mention that patient autonomy and balancing everything is obviously very important in this issue, and it really just hasn't been, it hasn't really hit the mark of treatment up until the last couple months, and obviously there's still a lot more that needs to be done within this issue. So justice and equity in healthcare, while I was doing research on this, I thought it was very interesting to see all of the geographic, socioeconomic disparities within this issue. And it just really seems like we as a country and as a healthcare system are not hitting that mark on making sure that everyone has equal access to these treatments. And it's been really interesting to see that a lot of states that are more isolated, a lot less people are likely to receive treatment for this. So the role of healthcare providers in this issue, after doing a lot of research, there are ideas of maybe having people include, when you go to the doctor, they say, oh, like, do you smoke or do you drink or use substances, anything like that? But there typically aren't a lot of follow-up questions. So they were thinking of maybe making that more part of the procedure, asking more questions if people are using substances, and just making it less of a stigmatized thing so that people feel comfortable discussing this with their physician and seeking help if needed. For future directions, like I said, adding that to part of the procedure, but also making sure that people are able to share their story. There was an article published by the New York Times that mentioned a man going to the doctor, discussing it, but it was actually his neighbor who was the doctor, and discussing his issues with substance abuse. And he said he was very embarrassed to talk to him because he thought that maybe people would think he was less morally upstanding and things like that. So just making sure that we can kind of get rid of the stigma around it and have open conversations in order for people to share their stories and realize that it's a very common health issue that a lot of people go through. So a lot of education and a lot of compassion through the care lens and things like that in order to make sure that people are getting adequate health care. Thank you so much.
When I am so in EPIC, the electronic health record, if you want to look at someone's drug treatment records, you have to break the glass. And then it says this in an alert window, and then it tracks who exactly is looking at the chart. And you're not supposed to look at charts for drug treatment without the patient's consent. The stigma cuts both ways too, because a lot of users have stigma about themselves and they don't want to acknowledge that they're receiving treatment. But at the same time, for me, I need to know it because there might be medication interactions and so on. And so I'm curious how you would navigate that privacy issue. Should I be able to look at it? Should I respect their privacy? What should I do there?
Yeah, in my personal opinion, I think obviously doctors took an oath and obviously want the best for their patients. So I think it would be really great if doctors could see it. And I think that, like you said, there's just a stigma definitely both ways. So what I'm suggesting is just more room to discuss it and more of an open conversation with your physician, and starting that socially and in med school and things like that so that people can feel more comfortable discussing it. Because I definitely think it is a huge issue. And when I was doing a lot of reading about it, a lot of people said that they are in denial, or even the statistic above, 3/4 of people think that they can handle it themselves. So yeah, I think, thank you for bringing it up, because I think that would be a really good thing for physicians to just be able to see.
It'd be nice, but I feel like, if they don't want to tell me on some level, I'm like, I don't want to respect that, but I don't know. I need to know if they're taking methadone. It's really complex.
Thank you, Anna. Thank you very much. So our next speaker is Carly, and she's going to speak about xenotransplantation. Welcome, Carly.
Hi, everyone. My name is Carly, and I'm here to discuss xenotransplantation, or the transplantation of genetically modified animal organs to the human body. So why are we discussing xenotransplantation? 17 people die every day waiting for an organ transplant. Hundreds of thousands of people suffer from diseases like cystic fibrosis of the lungs, liver failure, kidney failure, heart disease, and they need a life-saving organ. So they enter a wait list, but the problem with the wait list is that the number of people on the list greatly outweigh the number of people donating organs. And on top of that, their placement on the list depends on factors out of their control. What disease do they have? How long have they had it? What's the severity? What's their genetic makeup? And non-medical related factors. Where do they live? What's their financial capabilities? And so many people die before they even move up the list, before they even get off the list. And so scientists have proposed a solution. What if we use animal organs? They're more readily available. Maybe everybody could have a life-saving organ. They like to use pig organs because they're in similar size as human body organs. But the problem with animal organs is that they produce a molecule called alpha-gal. And the human body is programmed to attack alpha-gal. So this is why we always hear about the human body rejecting these animal organs. And so what scientists have discovered is that they can genetically modify the animal organs using genetic modification technologies like CRISPR technology, and they can remove the gene that produces alpha-gal, completely removing the molecule from the organ and making it more compatible with the human body. Xenotransplantation originally began in the early 19th century. It began before they had genetic modifications. So researchers were starting with smaller organ transplants like skin grafts, and they moved up to larger like kidney transplants. And they were testing these things on brain-dead individuals. And the individuals would pass away after a few days, a few weeks, maybe a couple of months. And it was all due to infection or the body rejecting the organ. And so that's when they discovered they needed to genetically modify the organs. But in 1999, the FDA banned the use of any non-human primate organs for human transplantations. And so this means this very specific permission needs to be given by the FDA in order to perform these surgeries on a human being. 3 people have received this permission. 2 people received genetically modified pig hearts, and 1 person named Richard Slayman, who we discussed in class, received a genetically modified pig kidney. The 2 individuals who received the pig hearts were the first 2 ever to receive a genetically modified pig organ, and they both passed away 2 months later. And then Richard Slayman came along and became the first to receive a genetically modified pig kidney, and he actually recently passed away, and it was about 2 months after his procedure as well. And so we have to ask ourselves, is xenotransplantation even ethical? At first, you might think it's ethical because you're looking from a justice lens, and right now the current system with the wait list is very unjust. Justice refers to people getting what is fair or what is their due. And right now, everyone should or deserves or should have their life-saving organ, but they don't, and their placement on the list is due to unfair criteria. And so animal organs, which maybe could be given to everybody, seems like it really solves this problem. But there are 2 big issues with xenotransplantation. The first one is infectious disease. Animals have hundreds of diseases that the human body isn't equipped to fight. And so someone receiving a genetically modified organ could still contract one of these diseases and potentially spread it to friends, family, or the rest of society. And this is one of the main reasons for the FDA ban. Think about COVID-19, the zoonotic virus that resulted in a global infection and killed millions of people. Another issue is that xenotransplantation could violate the patient's autonomy, as well as violate their privacy and the privacy of their loved ones. Normally in research studies, the patients have autonomy. They have the ability to back out of the study at any point, but people undergoing these procedures don't have that ability because they can't give the organ back. On top of that, because of the high risk of infection and these zoonotic viruses, anyone that undergoes this procedure is sworn to 24/7 surveillance by medical professionals and the FDA. This also means that anyone who they interact with is also sworn to the same surveillance, so they've lost their privacy. We also have to analyze xenotransplantation through the lens of healthcare professionals, who are always acting for the patient out of beneficence and non-maleficence. Beneficence means healthcare professionals want to do what's best for the patient. They want to take positive steps to help others. And non-maleficence means they want to abstain from causing harm or from imposing risk on the patient. When healthcare professionals participate in these xenotransplantations, they're potentially causing harm or at least putting a risk of harm due to the infectious diseases that the patient could contract and that the rest of society could contract. And so where do we go from here? So after the first 2 individuals passed away and then Richard Slayman passed away, it kind of seemed like maybe xenotransplantation wasn't quite ready for clinical use. But scientists are still trying to fully understand it. They're trying to fully determine why these individuals passed away, since they were very sick and had many medical complications. And they're trying to improve the technology the best they can. And they're continuing to do these tests. So for example, after Slayman's death, a woman became the second person to receive a genetically modified pig kidney. And so now within the next couple of months, all eyes are on this case to understand if xenotransplantation could be a future healthcare solution. Thank you.
How much should non-primate animals be the subject of our ethical considerations? Like, why draw the line at primates? Pigs are pretty intelligent.
I don't know, to be honest, why they worded it that way or made that decision. I think that any animal is kind of the same. Like, I don't think that there's like an ethical reason to use one over the other or to not use one or the other. That's just my opinion. And yeah, they didn't specify why they specified that.
The first heart transplant, I think, survived for less than a week. Human heart. So I don't know. It seems like our standards have maybe changed for what's acceptable in terms of an effective treatment. We no longer accept that things might take time to develop. I hate at conferences when people are like, I have a comment, but and what do you think? But what do you think of that?
Yeah, I agree. I mean, the people that had received that permission from the FDA were people that were extremely sick. They were people that were more sick than somebody, like a normal person that was on the wait list. So they already had so many medical complications and they're so desperate just to live a little longer that they were willing to undergo these kinds of procedures. And so to them, it may have been considered successful. But I think to scientists who, to them, a successful genetically modified organ would last someone maybe years. And that's their overall goal, is always to improve and improve. So.
Thank you, Carly. Thank you. So our next speaker is Neve. Addressing the problem of the shortage of primary care physicians. Sorry. Thank you, Neve.
Thank you. So, as Professor mentioned, I'm Neve Esfahani. I'm a junior and a biology major. And today I'm going to be talking about our shortage of primary care physicians, specifically in the United States. So, as the US tends to do, we outspent every other country, every other developed country in healthcare by a significant margin. We're at 16% as of 2021, and the average for developed nations is closer to 9.6%. Going along with this, we have fewer physician consultations per capita and fewer practicing physicians per 1,000 members of our population. This, and unfortunately in conjunction with our increased spending, results in worse health outcomes for our population. The other thing to note is that while we did spend more than every other country in healthcare as a whole, we cut our spending from 2016 to 2020 on primary care from 6.2 to 4.6%. So at 4.6, it's roughly half the average of developed nations and what they spend on primary care. So I'm going to go into a couple of the reasons why we lack primary care physicians here in the US. First and foremost, they're paid less than specialists. The US is second place as far as the pay gap between specialists and general practitioners. First place is Belgium. The other reason is they're kind of looked down upon in the medical community and by the general public as being less skilled than specialists. That goes along with why they get paid less. It's seen as kind of an easier specialty to get into, but that's actually factually incorrect, which I'll get into later. So these are just a couple of the reasons for why we have a shortage of primary care. Now I'm going to get into what the results are of that shortage. So I think rural America is a really good example of this. There's a shortage of physicians in general, but there's also a very extreme shortage of primary care physicians in rural areas. And in those areas, we see a 6.2-fold increase in obesity compared to in metropolitan areas. As you can see here, we also have overall worse health outcomes for populations when we have a shortage of primary care physicians. So the US is first in percent of adults aged 18 and up with multiple chronic conditions. We're first in obesity, that's well known. Our life expectancy is lower than most developed nations. Maternal mortality after pregnancy is higher, infant mortality is higher, and the list goes on. It's really unfortunate. The other impact is on the healthcare system as a whole. When you have fewer primary care physicians providing their patients and their population with important preventative care like screenings and vaccinations, you have increased stress and demand on the rest of the system. You have more patients going to the emergency department because their initial complaints went unchecked, and you have more patients going directly to specialists because they never first brought their issue to their primary care physician. I'm sure many of you have witnessed the extremely high wait times at emergency departments. There's also really long wait times to get appointments with specialists. It can be 6 months to a year to see a dermatologist. And overall, like a couple other people who spoke today mentioned, the outcome is just poor health outcomes for our population. So the solutions. There's a couple. One that I thought of was AI. It can help take some of the administrative load off of primary care physicians. We all shadowed during our time as interns, and we saw there was a lot of note-taking, a lot of charts, documentation, administrative stuff, and that takes away from the time that providers can spend with their patients. AI can help a lot with charts as far as listening into conversations doctors have with their patients and then documenting that. However, there is the ethical issue of privacy. It's not really well known where the information goes. It's referred to as the black box. So patient privacy is a concern when using AI. AI is also extremely important for primary care because they're considered to be the base of the healthcare pyramid. So they have to communicate with every specialist that their patient might be seeing, and they have to send over all those reports and charts to those specialists so that the patient can get comprehensive care. And AI can really help streamline that process. On a similar note, social work is also really important. It can help, again, take some of the load off of primary care physicians that isn't necessarily work that needs to be done by an MD. These include ensuring that the patients adhere to the medications prescribed or behavioral changes like diet and exercise recommended by the physician. And it's well known that social determinants of health and behavior are far more important for long-term health outcomes than acute medical treatments. So social work can really have a big impact on that. Finally, training and education. Contrary to popular belief, the bottleneck for primary care physicians is not at medical schools. Since 2002, the number of medical schools have increased by 31%, which is pretty closely tracking the population and the number of people applying to medical school. However, it's the number of residency slots that is really slow to adapt to the increasing number of medical students that's preventing a lot of people from becoming primary care physicians. Two of the three biggest shortages for residency slots are in family medicine and pediatrics. Third one is gynecology. So increased funding going towards training hospitals, which are almost always at capacity, and residency slots for primary care could do a lot of good in this situation. Finally, there needs to be a cultural change. The era of looking down on primary care physicians as being less skilled really needs to end. It's not true, and to suggest that because they're less specialized in a specific field of medicine that they can't have as big of an impact on their patients' outcomes is ridiculous and not founded in truth whatsoever. And the final solution would be increased compensation, monetary compensation for primary care physicians. It's unfortunate that they get paid a lot less, which decreases incentive to go into that field. One example of a method that was attempted to solve that is concierge medicine, where you pay a fee to be a small group of people attended for by a set number of doctors. And that worked. People typically enjoy that system a lot better than they do the typical system. However, it raises issues of equity and justice because by nature it cannot be a solution for the entire population because it does nothing to address the fact that there's not enough primary care physicians. So I think we're going towards these solutions, but it's going to take time, as all solutions do, and I'm optimistic.
What do you think of the trend of NPs and PAs taking on primary care provider roles instead of doctors?
I think that's a solution. It's kind of a reaction to an issue. It's similar to having, in my eyes at least, having social workers do some of the work that you don't need to be an MD to do, except obviously they're still licensed medical professionals, so they're able to take a lot of the load off MDs and hopefully spend more time with their patients. So I see it as a positive.
I'm curious to know why, even though there's like such a lack of primary care providers, their, I guess like supply and demand salary hasn't increased. Because like for other specialties, like I can speak to, I guess, podiatry, like in recent years, there was like a shortage, and like in hospitalist systems, salaries like kind of skyrocketed. So why is that also not being seen in primary care?
I don't have the perfect answer. I'm not sure. I suspect that some of it is due to, as Dr. Burke mentioned, a lot of the load of primary care physicians is being taken up by PAs and NPs. So you'll have, especially in EDs, like you might have, I don't know if you've ever been to VMC, but like you might not even be seen by an MD. So you may only be treated by a PA or an NP, and then they report to the MD. So I think some of their workload is being taken up by other professions because they're in such a big shortage.
In your research, in your research, did you see any discussion of making it easier for foreign doctors to practice in the United States?
I did not, unfortunately.
So thank you. And now, last but certainly not least, we have Sydney with a discussion around translation services in healthcare. Welcome, Sydney.
Thank you, everyone. I know you've all been very patient sitting through all these presentations, so hopefully we end on a good note. But hello, my name is Sydney. I'm going to be talking a little bit today about some of the ethical implications of translative services in healthcare. All right. So jumping out of a plane, for some of us who are maybe more the adrenaline junkie kind, this statement might elicit feelings of excitement and adrenaline. I know for myself and for probably most people, this statement elicits feelings of fear and anxiety. But let's just say hypothetically that we were able to muster up the courage to go and get on a plane in the middle of the sky and take the leap of faith out of the side of it. Now, halfway in between the sky and the ground, we realized that we got no safety briefing. And as we try to figure out how to deploy the parachute on our back, we are frantically searching for any kind of instruction on how to do so. We find directions, but we find that they are in a language that we do not understand. And we are now panicked, trying to figure out how we are going to save our lives and overcome this language barrier, and also why we were subjected to a system and equipment that was not designed for our safety in mind. And this is the essence of the experience faced by the 29.6 million people in America who have a limited English proficiency or LEP status. They too, as we did in our parachute example, have to first overcome their fears of medical mistrust or the social and structural barriers that are already in place to their care. And so good translative services are the final step in making sure that they land on the ground safely. So, there have been some steps already taken to try to combat this problem. First, Title V of the 1964 Civil Rights Act mandated that translative services were required for people with LEP status as protected under anti-discrimination law. And this right was further clarified in 2000 by President Bill Clinton when he signed Executive Order 13166, which stated that any healthcare institution that received funding from the government was required to provide an interpreter for patients that needed it. Now, problem solved, right? Why am I even giving you this presentation? Well, this executive order had one very fatal ambiguity in that it did not specify who could be doing the interpreting and what qualifications they needed to be able to do so. And so as a result, you have healthcare institutions bridging this gap for their LAP patients into providing them quality healthcare by using ad hoc or as necessary interpreters. So, what are some of the ethical problems with using these ad hoc or as necessary interpreters? Well, there are two kind of major routes in which this usually manifests in a healthcare institution. Firstly, healthcare institutions will use healthcare providers to act as an interpreter for these patients. Now, I think it's important to note here that being bilingual does not make you a competent interpreter. Those are two very different things. So competency, from an interpreter perspective, interpreters go through very rigorous training to be able to have that kind of certification. And so providers that are just bilingual would not be going through these kinds of trainings, making sure that they understand the medical terms, not only in English, but also in the language that they would be interpreting for, as well as understanding the cultural sensitivities related to the language that they are interpreting in. As I'm sure you've all heard, for example, in Spanish, sometimes the verbiage that you use is reliant on your geographical location. And so that's really important in making sure that patients are receiving the most accurate medical translation and treatment. And when this is disregarded, it can lead to medical errors or a violation of a patient's right to autonomy and informed consent if it happens that they don't understand the treatment plan that is being explained to them. And that's important because it only further entrenches and exasperates feelings of medical mistrust with the healthcare system and these communities. Now, in cases of family members interpreting for the patient, sometimes patients will request that family members interpret for them as they provide a sense of comfort for them in a sometimes stressful situation. However, that's not always ethically permissible. And that's because family members seldom have the ability to be a completely neutral interpreter. As I'm sure you all know from dealing with your own family members, they usually have some sort of say in how they think, what you should do, what you should not do. And that certainly does not stop in this medical context. If anything, it's even more heightened. So the one way that this can manifest is that a family member, in telling the provider the patient's symptoms or the kind of, telling them their symptoms, they might insert their own kind of narrative into that story about how the patient is feeling, what they're experiencing. And conversely, if a family member is interpreting for a provider, they might, in telling the patient, also insert their own kind of opinions and feelings about the treatment and the treatment plan. Again, this kind of underwrites our patients' rights to informed consent and autonomy as well. I also think it's interesting and important to consider the burden that would be placed on specific family members in this instance. So specifically thinking about minors who are asked to interpret for their parents. Oftentimes, minors might be asked to be pulled out of school so that they can attend an appointment with their parents so that they can provide this service for them. Or minors might be subjected to potentially psychologically disheartening or damaging situations that are really stressful just because of the medical context, or have to deliver really bad news to a parent, and that's also not okay. And so that becomes an issue of justice for this population as well. So if ad hoc interpreters should not be the default, then licensed ones should. However, that is not a super simple solution, and that is because there is a massive translator deficit in this country. For example, in 2023, it was reported that for the 900,000 Chinese-speaking individuals in America, there was only 500 interpreters. So this is a major deficit. Oh, wrong one. And so can technology help be the solution in this case? So one of the avenues that this has been proposed to is through the usage of telemedicine. And telemedicine essentially either allows for an interpreter to be kind of streamed, like I see in this photo here, directly into an appointment, or they will kind of conduct the visit virtually. And so then a patient can kind of just have the interpreter right there with them. I think one of the benefits of this solution is that it kind of doesn't put any extra onus on the patient to kind of go out and get this interpretive service unless a patient is being asked to supply a device to be able to conduct this appointment. Then I think that can sometimes have some difficult implications. But I think one thing about this solution is that it doesn't necessarily increase the number of interpreters available. It just kind of alleviates the problem but doesn't solve the problem. So artificial intelligence, as I'm sure we all love AI right now, but it's definitely been proposed as a solution to kind of generate more interpreters, if you will. But I'm sure from our own usage with Google Translate, we know that it is certainly not without error, especially when it comes to language. And I think it's especially important to consider how this error might manifest in populations where the language is not as commonly spoken in America, and so the data sets to train these artificial intelligence machines would more likely mess up on those already small and likely marginalized populations. And additionally, as I said earlier, language is so much more than just linguistics. It's also the cultural sensitivities that inform it, and so it would be important to consider how we would train an artificial intelligence system in that way as well. So I don't have all the solutions as to how to best integrate technology into interpreter services. However, what I do know is that any solutions that we do come up with should center the LEP patient population and what is important to them and their right to quality healthcare. In the meantime, while these solutions are being figured out, I think it is all the more important that physicians continue to be educated with respect to culturally competent care, and that we work to increase diversity in the medical field, because that can help to ease a patient's anxieties, as well as addressing the social and structural determinants that can prevent those populations from accessing care in the first place. At the end of the day, we all have an ethical obligation to ensure that the importance of care for this population is not lost in translation. Thank you.
Where do you come down on this debate that is not just in interpretation in medicine, but in translation in general, that you should try and capture the word-for-word meaning of something versus like a subtle poetic meaning, I guess I would call it? What do you think is more useful in a medical setting?
That's a good question. I think I could imagine that if an interpreter could understand, again, because of their training, that maybe a patient was meaning to say one thing or just not able to find the words, instead of just translating it word for word, it might streamline the process to be able to kind of just relay to the physician. I think, again, it would be important. I mean, interpreters are trained professionals, and so if a family member or a physician who wasn't fully trained in that was doing that, I think that can be a little bit more dicey. But for interpreters who are trained in this and have high level of expertise, I think that could be necessary to streamlining the care.
In my experience, I really prefer interpreters who are able to give cultural notes. But some of the training at most of the interpreters at my hospital is that they do it word for word, like literally. But like when you have, say, like a Spanish-speaking patient who says they're hechizado, that translates as like hexed. Some people hear that and they think it's like they're mentally ill, but it's like an expression and an idiom. And having an interpreter who can like tell you like, oh, it's this word and it doesn't quite mean supernatural forces are at work, but I don't know. I would love to see an overhaul in like licensed interpreter like education, because it's like those cultural notes are so important and they're often lost literally in translation.
Definitely. And I definitely think that there's also, as I was researching, I was kind of surprised. I was looking to see if there was methods for, or if you know about this, like providers being able to be certified as medical, but like in their medical schooling, or if there was an avenue there.
There must be, because I've interviewed people for residency who were certified interpreters, and I think they did that in medical school.
Yeah, it wasn't a super widespread thing. So I also thought that was another way to, I mean, obviously even more streamline the whole ordeal, but definitely like those cultural competencies are so important. Yeah.
Thank you very much, Sydney. Thank you. And this concludes our event. So I hope that, as me, you could see the vast, range of topics that those students chose out of their heart, because my only advice was, just pick a topic close to your heart, because it really matters to you, and it will matter to you, and it will also make a difference, because those topics and articles are published on the Markkula website. And also, they have been presented tonight to you all. So I hope that you could see, the passion behind every one of those topics that were very different from one another, but yet, with common themes like social justice, like transparency or the lack of thereof, and also, the issues we have in our society in general and in our world. So I would like to thank you all, dear interns and dear Honzel Fellow, for sharing what was close to your heart this year, and for really taking the time to research the topic, to write about it, and to present it tonight. Because thanks to you, who have become kind of small experts in that field, we could all learn a lot tonight. I also would like to acknowledge a few people, because as I said, those articles are published on the website, and it's thanks to my wonderful colleagues from the Markkula Center for Applied Ethics, and more specifically Joel and Debbie, who helped me greatly, reading, because of course I'm helping the students, mentoring them for those articles, but then I have an entire team of experts, really reading through every article and, commenting and helping the students as well, and then, publishing it. So it's a huge work for the center, but we are very proud and grateful for that, and thank you so much, Joel and Debbie. And of course, Monica as well, who is here as well, and who helped us, organize this event tonight, as she helps, every event for the center. So those are a few of my colleagues. I would like also to acknowledge Don Hyder, who is my executive director of the center, for his support for this symposium. As I said, the first version of it was last year, so this is something quite pretty new, and we're very proud of this event. Then I would also like to say a few words about, the power to make a change. And I think it was Kate who wrote that. And I'm very happy to hear that through all your presentations, because the main topic of this year was, of course, bioethics, but not only. I hope that I could empower you all to see that you have this power to make a change towards, the topic that is close to your heart. Basically, we inherited of a society, but it doesn't mean that it has to remain like that. We are, you are the new generation, and you have this power to really make a difference and have a positive impact on the world. And I would like really none of you to forget that. Not now and never, actually, because, during your career and your life, you will see that you will have many opportunities to make this change and to have this impact. And so, related to that, I just wanted to share this quote. So it's a quote from Gandhi that you all know, of course, and it says, "Live as if you were to die tomorrow and learn as if you were to live forever." So this is my wish and my blessing for you, all of you. It's really to live life fully and to really enjoy every moment in your life, not only professional, but also private life, your friendship, your everything that is in it, because it's really wonderful. We are very privileged to have this life, and I hope that you will all, enjoy it very much, but also that you will also learn from it. And not only, again, at the medical school or the law school or whatever school you are going to go to, but also, through your relationships, that you are going to learn, as much as you can, and that you're going to grow, as I could see you grow this year. So, again, I would like to thank you so much for your time and for being with me this whole year. It was a huge privilege and honor to be with you. And this is something that, I'm very grateful for. Again, last but not least, I would like to thank you again, Shelby, for her amazing support and, for being with us the whole year, for hearing me twice. Can you imagine? She was already there last year, hearing all our discussion this year again. So thank you, Shelby, for your patience for that. And I would like to also announce officially who will be my new Honzel Fellow next year, since Shelby is going to move to Boston. And congratulations again for that. My new Honzel Fellow is one of the members of this cohort this year, and this is Sydney Shelby, who is, right there. So Sydney, really, thank you very much for applying, and it's a huge privilege to have you with me starting in September. So this being said, there's a small reception for all of you to attend. Please stay at the reception and get this opportunity to talk to our students and to the parents and everyone present here. Thank you again very, very much.